One of the most common side effects with SRS or SRT, again, this is because of the vascular endothelial damage causing leaky vessels. There's blood-brain barrier disruption. You have got cytokine release. You've got inflammatory response. And that's one of the major toxicity or dose-limiting toxicity with SRS or SRT, more relevant in more eloquent areas of the brain. So take-home messages. It's a highly conformal treatment with very high dose per fraction. Precision is the key. Very minimal room for error. It usually causes direct DNA damage and the vascular damage, but there is evidence for immune activation as well through antigen release. We also have to select our regime quite carefully based upon the tumor size, location, number of metastases, prior radiation. So there are a number of factors that need to be taken into account to come up with the right protocol for the right patient. Radiation necrosis remain the major side effect of treatment, and hence longer-term follow-up with regular imaging is required in order to monitor those patients. With that, I thank you very much for listening ever so patiently, and sorry about the initial hiccup. I can take any questions.
Yeah. Discussion and question at the end.
Sure.
So we'll finish. Thank you very much, Dr. Fawad.
Thank you very much, Dr. Fawad. I think we will be having a discussion and question answer at the end. If we have
started Gamma Knife here with this team, and in Gulf countries, I am also the pioneer who started this technology. So topic of my discussion is hypofractionated versus traditional gamma knife radiosurgery in New Horizon in precision neuro-oncology. So this is the history about this technology. Professor Lars Laxell, he was a neurosurgeon who started this concept of radiosurgery. So in 1967, first treatment with gamma knife was done for tremors. He did thermotomy with 180 gray. In 1969, first treatment of acoustic neuroma was done at Stockholm University Hospital. And 1970, first treatment of AVM by Laxell and Professor Steiner in the same institution. इसमें ये एक वीडियो है, ये साउंड आएगी. So gamma knife machine is actually...
Our brains hold our memories, our dreams, our passions. A lifetime of experiences. They make us who we are. But the brain is delicate. This precious organ needs the utmost protection. Because one memory lost is one too many. This is what drives us at Elekta. We know that when it comes to our brain, precision is the only option. Based on decades of unrivaled innovation, Elekta Esprit delivers exceptional accuracy, seamless integrated planning software, and flexible frameless or frame-based workflow enable you to treat the most challenging targets. With 192 simultaneous high-dose radiation beams, while safeguarding healthy tissue, preserving what's important. Because when you protect the mind, you protect the person.
So now I will discuss about traditional single fraction radiosurgery with gamma knife machine. Traditional gamma knife SRS is a high-dose single fraction treatment that has been found extremely effective for a large spectrum of malignant and benign neurosurgical conditions. I will not talk about the other neurological disorders like AVM or the functional radiosurgery. We are talking only about the tumors, benign or the malignant. So traditional gamma knife radiosurgery is performed. Actually, traditional we were performing with the old machines that was up to 4th generation, because there we were using only the frame. So we were using a rigid stereotactic frame for immobilization of the head fixed to the outer table of skull under local anesthesia with the old versions, and now with the new versions we are using also thermoplastic mask. So now only it is possible with the new machines to do hypofractionation. So traditional radiosurgery has limitations that include the size of single tumor, which is bigger than 3 centimeters, located in the allocant areas, and has more possibility of toxicity in the normal brain tissue. Hypofractionated. Usually with the gamma knife radiosurgery, we are doing hypofractionation only with 3 to 5 fractions. Fractionated stereotactic radiosurgery is the future. Professor Arjun Sehgal, he is our president of ISRS. This is International Stereotactic Radiosurgery Forum. The evolution of single fraction gamma knife radiosurgery has continued beyond early generations with the invention of new machines like ICON and SBRT. Stereotactic radiosurgery has become more flexible, expanding from a single fraction to fractionated SRS. Fractionated SRS is performed using a frameless thermoplastic mask for immobilization of the head. It has a steep fall-off and has an excellent local control with the less adverse radiation effect. Hypofractionated SRS maintains sub-millimeter precision up to 0.3 millimeter. So radiobiology, Dr. Fahad, he has explained very well. So there in the 5R principles of radiobiology, only these 3 are affected. So during fractionation, or between the fractions, repair of sublethal damage of the normal brain tissue surrounding the target takes place. Then reoxygenation occurs between the fractions by which previously hypoxic, which are 2 to 3 times more radioresistant, tumor cells become more oxygenated, making them more radiosensitive. And reassortment refers to the redistribution of the tumor cells into more sensitive phases of the cell cycle between fractions. Usually, it is literature tells that 24 hours, it takes 24 hours to repair. So it promotes the transition of cells from radioresistant cell cycle phases S and G2 to more sensitive phases. So there is also another thing, alpha-beta ratio in radiosurgery. In radiosurgery, it is a radiobiological parameter that describes how a tissue or tumor responds to fraction size of radiation. A low alpha-beta ratio means the normal brain tissue has a high ability to repair when the dose is divided into fractions. A high alpha-beta ratio means the tissue does not care if you divide the dose up. It is not the alpha-beta ratio that matters. It is the alpha-beta ratio of the target relative to the surrounding tissue. The brain is a late responding tissue with low alpha-beta ratio of 2. This means it is more sensitive to fraction size than to total dose. Brain mets and GBM usually have high alpha-beta ratio of 10 gray, highlighting the therapeutic advantage of fractionation. So these are the alpha beta ratio of different organs with single fraction. How before hypofractionated SRS. What is the size of the lesion or tumor cavity? Are there any patient-related factors like performance status, anxiety, or claustrophobia that may potentially impair their ability to comply with multiple treatments? Did the patient receive prior radiation therapy or SRS? In post-op cases, what is the anticipated time between the resection and start of radiosurgery? Usually, we wait for 1 to 2 months after the surgery. If patient receiving systemic therapies, what will be the interval between systemic therapy and radiosurgery, and what is the clinical target volume margins needed to avoid marginal recurrence, and what is the appropriate dose required to obtain tumor control? So, selection of the patient. For hypofractionated stereotactic radiosurgery, the following is the criteria for selection. Large lesions, brain mets, diameter more than 2.5 to 3 centimeter or volume more than 10 to 12 cc. Lesions close to the critical structures, optic nerves, optic chiasm, brainstem, thalamus, basal ganglia, motor cortex, speech cortex, and cranial nerves. Benign tumors requiring organ preservation, meningiomas, vestibular schwannoma, pituitary, adenoma, cavernous sinus tumors, usually cavernous sinus meningiomas, glomus tumor, and malignant tumor, brain mets, and recurrent GBM. So these are the doses for hypofractionated SRS, which we follow the International Stereotactic Radiosurgery Society guidelines. So for brain mets, 2.4, this is actually, 2.5 to 3 centimeter. It is 25 gray in, actually this is not written, 25 gray in 3 fractions, 3 to 4 centimeter, 30 gray in 5 fractions. Post-op cavities, 25 to 30 gray in 5 fractions. Usually post-op cavities are, have the big volumes, so we use 5 fractions. And allocant areas, 25 gray in 5 fractions. In meningiomas, 21 to 24 gray in 3 fractions or 25 to 27 gray in 5 fractions. Vestibular schwannomas, 25 gray in 5 fractions, pituitary adenoma, 25 gray in 5 fractions, and allocant areas, 25 gray in 5 fractions. So this is the estimated risk from, this is the table which showing estimated risk from dose response models for normal tissue constraints probability of brain radionecrosis following SRS for the brain mets at various dose volume. Okay, this is a case of 58-year-old female with a single left occipital mets. Primary was CA breast. The volume of this tumor was 7.5, and we have hypofractionated as there was a lot of edema around this. So the dose was 25 gray in 3 fractions. So first is the pre-gamma knife MRI, and 3 months post GK, almost the tumor disappeared. So this was the case of 65-year-old female with a single mets. Primary CA breast. Patient underwent surgical excision, and the tumor cavity, after that, within 1 or 2 months, there was a recurrence in the tumor cavity. This patient didn't go for any radiation therapy brought to us. So the volume was about 12.1, and the dose was given 30 gray in 5 fractions. Follow-up was 6 months, and in the last picture, you can see that almost the recurrences disappeared. This is again a case of multiple brain mets. There were about 7 brain mets in different locations. Patient was 70 years old, female. KPS was 90. Primary disease was CA breast. Total volume of all these 5 was 17 cc. So the dose was 25 gray in 3 fractions. So the above pictures are pre-gamma knife, and the down pictures, this is 3 months post-gamma knife. Almost you can see that the tumors have disappeared. This is another case of GBM. Case 46 years old female, KPS 80, GBM, volume was 5.4 cc. As the tumor was very close to the midbrain, to the pons, so we decided to hypofractionate. So follow-up was 6 months, and you can see that almost the tumor has disappeared. Only 3 month follow-up. 3 month. This is 6 month. Complications. So we can face the following complications: radiation necrosis, brainstem injury, optic neuropathy, cranial nerve injury, vascular injury. Radiation necrosis is the most common complication which we face. Both SRS and hypofractionated SRS deliver ablative doses of radiation to the target volume as well as the brain parenchyma surrounding the target, and hence predisposing the treated volume to a risk of radiation necrosis. So on MRI, you can see that on the day of gamma knife, then we treated this patient. After 3 months, almost the tumor disappeared, and after 2 years, again, there was a radiation necrosis. And usually radiation necrosis appear like a Swiss cheese or soap bubbles on MRI. So it is always difficult to differentiate oftentimes from the tumor progression with a variable asymptomatic to symptomatic. Therefore, MRI with perfusion, MR spectroscopy, or PET CT scan is advisable for the differentiation.
The time is probably finished.
Okay.
So,
So the other complication, we can face brainstem injuries, so I will not go into detail. Optic neuropathy. Optic neuropathy is very important because perioptic tumors, we are treating perioptic tumors. So optic neuropathy is one of the most feared and devastating complication. Overall, the incidence of optic neuropathy is low after SRS, less than 2.5%, and very low in the hypofractionation. So in general, constraints for optic neuropathy are 8 gray in single fraction, 20 gray in 3 fractions, and 25 gray in 5 fractions. So then third, fourth, fifth, sixth nerve toxicities we usually face when we are doing cavernous sinus tumors. So the usual doses of 14 to 34 gray in single fraction used for pituitary adenoma and 12 to 18 gray in 1 fraction for cavernous sinus lesions are expected to the result in a low risk of damage. So 7th and 8th nerve toxicity, based on the literature view, toxicities of 7th and 8th nerves came from radiosurgery for vestibular schwannomas. So I will, vascular injury occurs when we are treating cavernous sinus meningiomas or pituitary adenomas. So we should take care of the dose. No vascular injury is reported after hypofractionation, delivering 19.5 to 21 gray in 3 fractions or 25 gray in 5 fractions. So take home message. Hypofractionation is an established radiosurgery technique for benign and malignant brain tumors in the last 10 years after the invent of advanced gamma knife mask-based machines like 5th and 6th generations ICON and SBRT. Patients before procedure should be discussed and selected by a neurosurgeon, radiation oncologist, and medical physicist. SRS radiosurgery is feasible only for small and non-eloquent area tumors. Hypofractionation is the best option for large lesions above 10 cc volume, tumor beds, and allocant area tumors to avoid complications like radiation necrosis, nerves and brainstem injuries, or surrounding edema. SRS can be used as a primary mode of treatment in selected cases like advanced age and medically compromised patients. Radiosurgery can be used as a salvage therapy in patients with recurrent malignant tumors already treated with radiation therapy. Thanks.
Sir, thank you very much. Thank you very much, Dr. Aftab. I may request to all the speakers, please confine to the time because agenda is very much loaded and we can understand that the remaining speakers who will be coming after the next one will be having a problem for the short time. Dr. Muhammad Salim. ये बंद कर दे ये चला दे
सर ये प्रॉपर सही नहीं कॉपी हुई है कहाँ से कॉपी किया आपने
पहले चेक
शॉर्टकट है
सर आपके पास है देखें ट्रैक चला
जी सर डायरेक्ट
नहीं यहाँ तक 4K भी आ रहा है मैं वो मंगवा लूँगा
सर बताएगा
कर लें अगली शुरू कर देते हैं आप कंफर्टेबली
ये वाली है
आ जाए चलो ठीक लोगों का
आपके पास आया
उधर देखें उधर आए
चला कर दें सर की स्लाइड लगा दें
So I request to all the speakers, please confine to the time. And now I invite Dr. Muhammad Abid Salim to speak about clinical spectrum and outcomes of gamma knife radiosurgery, Dow University Hospital experience. Sir, please.
Thank you, Dr. Azhar. If you probably don't know, Dr. Azhar was the prime accomplice when we started gamma knife in Pakistan. So along with Dr. Aftab and me, he was our prime support regarding the radiation oncology, and found him very skeptical when we are treating brainstem lesions. He almost said that I'm not part of this. And but after 3 months, when the results of the gamma knife started coming, from that point I saw him. He's falling in love with stereotactic radiosurgery. So thank you, Dr. Azhar, for your support. So I will be talking about our experience with gamma knife radiosurgery at Dow University Hospital. So why it matters? Probably by now you have known that stereotactic radiosurgery has fundamentally transformed the neurosurgical oncology. We are able to deliver very high doses with a steep dose fall-off and excellent normal tissue sparing. And its indications has already crossed the tumors. Now we are in vascular and functional territories, and from brain it's now have spread to rest of the body. So our objectives are fourfold. Our experience at Dow Gamma Knife, the clinical spectrum we are treating, what pathologies we are treating, what are the outcomes, and review of complications. So at Dow, we started in 2021 to 2025. The patients treated were more than 2,500. The age range was 2 to 91. It was a retrospective observational experience, and primarily all cases were done in gamma knife icon model. This is the inauguration did by Sindh government, has actually did a very good support to us. As regards my personal experience, as you know, we started at NMI in 2008, and in 13 years, I treated about more than 4,000 cases. But when we shifted to Dow University, because of the government support and other things, our cases in 4 years were 2,500, which is a 100% increase per year. And I would like to praise my team there, Dr. Amjad Shahani, Dr. Sohail, Dr. Khola, and all the radiation and technology in showing the comprehensive coverage we are giving to the brain disorders. As you see here, the meningioma, acoustic schwannomas, pituitary adenomas, AVMs, and trigeminal neuralgia are the main things. Almost male-female gender portrait is same. Age range I have already told, that is widely applicable in pediatric, adult, and elderly population. We have now, as you have seen the talk from Dr. Aftab, that we are now also in fractionations, lesions and those which are near to the critical structures, and it shows now, gives us now more flexibility without compromising the accuracy. We have increasingly using the frameless technique. In fractionations, most of the time we are using the 5 fractions. And as you see in this graph, the trigeminal neuralgia and AVM we are all frame. Now, in the interest of time, I just quickly go through some of the outcomes of various treated pathologies, starting with the benign ones. This is an acoustic schwannoma, actually a very large one. It was treated with 12 gray in single fraction, and at 1 year you can see the result, and at 2 years it's already regressed. This trialite was from a previous experience, but I wanted to include this as this case we treated on gamma knife 4C. So you can see even the older generations, how effective they were, and we were interested in, for the longer follow-ups we treated, and then followed this patient for a long time, and you can see the sustained results. Similarly, another case you can see with sustained results. Craniopharyngioma, a deep-seated lesion. Actually, the cystic part was treated, and the solid part we treated with the gamma knife in 3 months and 1 year. You can see the very good result. Another case we treated at Dow, a larger one. You can see at 6 months and 2 years, excellent. It was treated on hyperfractionation, 5 gray in 5 fractions. Another case, it was just biopsied, this case, and they couldn't operate much on this case. And living with no choice, we treated on hyperfractionation, 5 days in 5 fraction, and found to be very beneficial, as you can see. Pituitary adenomas, we are treating both functional and non-functional adenomas. This is the residual pituitary adenoma. If you treat it in 5.3 gray in 5 fractions, and you can see a very good resolution. This is an interesting case. This lady is just 15 years old with typical Cushing's features, and we found a small microadenoma. And we also did the biochemical localization, which is typical for neurosurgical patients to undergo pitotal sinus sampling, and that actually shows that the left side is considerably high, showing cortisol levels. So we treated the left side microadenoma. It was in single session, 24 gray. And you can see in 6 months, it started regression. But more so, clinically, you can see how the change has occurred even in 6 months. It's a very good early response we achieved. Finally, the tumors, because of the deep-seated nature, we always get these cases and we treat them with gamma knife. In this case was treated in 3 fractions, 6.5 gray, a 25-year-old man, after putting the VB shunt, and showed a very good resolution, and then it is being followed up. recurrent hemangioblastoma. This thing with dicey. We have both results. Some of the hemangioblastomas, they did not show much response, but some shows a very good response like this one. But in some of the cases, we have seen patient recurring even after regression after radiation with gamma knife. So they need to be on the follow-up even after regression. Angiofibroma, this was a case who was operated and then reoccurred, is sent from our civil hospital here to help him with radiation. And this is the first case we treated with the angiofibroma with 18 grain single fraction. And we found to have very useful, the good resolution of the residual angiofibroma. Oligodendroglioma, as you know, always shows good response, both with chemo and radiation. This was a very large case, which was left out by the neurosurgeon that he cannot operate much on this. So we treated him with the gamma knife in 3.5 gray in 5 fractions with a good result. Pilocytic astrocytoma is considered to be a low grade, but when in deep locations and recurring, it's actually very problematic. So this case we treated with 5 into 5 fractions and found a very good result. Hypothalamic glioma, again a very deep-seated lesion in a critical location, and this one shows a very good response at 6 months, treated with 5 into 5 gray fractions. Few of the uveal melanoma were referred to us from our eye department. This one was one which we treated with 25 gray in single fraction. Shows some regression. And the problem was how to immobilize the eyeball. So we treated help of the ophthalmologist, scleral sutures to make it immobilize. Clival chordoma, it's very resistant, a recurring tumor. And we have few cases. One of these is this. This is the residual which showed a very good response. We treated a higher dose in 9 gray in 3 fractions, and is being followed even after a good response. This is just the reconstruction of how the things are improving. Cavernous sinus meningioma have always shown a good result, even with the lower dose. But this one is having some IVN problems, so we treated with fractionation, 4.8 gray and 5 fractions. You can see the result at 6 months. Petroclival meningioma, with 6.5 gray and 3 fractions, and this is regressed and much improved clinically also. This is a case which referred to us, was diagnosed as intracranial mesenchymal chondrosarcoma. He has surgery, he has conventional radiation and chemotherapy, still it was recurring. So and this is the result which we got given a higher dose in 8 gray and 3 fractions. The patient is also clinically well, except hemiparesis, which was already there. A solitary fibrous tumor. This is an interesting tumor. It recurs even after surgery, even after radiation treatment. So we have many patients who are being treated with after surgery with radiation, but every 6 months we see that there is some new tumor growing. So this was the patient who came with us with multiple lesions, treated with 25 gray in 5 sessions, and with a good result. Gliosarcoma. This was a smaller lesion. We treated with a high dose, and this was at 6 months and 1 year. The patient is also clinically well and is being followed up. Brainstem gliomas, because of the nature of the lesion and this site, we are treating it with the radiation in 5 fractions. Especially in adult cases, we are finding a good response, and the survival is as good as the conventional radiotherapy. This is the resolution occurring over time. Multiple brain mets, as gamma knife is very good indication. This is the typical resolution that we see. Another case. This was a boy with trigeminal neuralgia, and investigation found to have a large AVM. So we just treated the AVM regressed, and his trigeminal pain was also gone. And we have a very good series of trigeminal neuralgia cases also routinely being treated at our center. This is in the functional territory, which I will spare you from. Yeah. So we can have acute reactions, which are usually mild. Subacute swelling can occur in 3 to 10 months, but usually manageable. And there are some rare late reactions also. Like this AVM in a child we treated, 6 months was showing peritumoral edema, but we treated with steroids, and all edema was gone, and patient is clinically always were well. So it's a safe, precise, and versatile neurosurgical tool, established tool now. And at Dow University, we are having a very high volume with reproducible outcomes, and is supposed to expand its role in other than in neuro-oncology, also in functional neurosurgery. Thank you very much.
Thank you very much, Dr. Abid. I like it. Very nice. मैं पूरे टाइम पे ख़त्म कर दी. So our next speaker is Dr. Aurangzeb, who is a neurosurgeon, and the topic of talk is clinical efficacy, multi-fraction treatment of gamma knife for brainstem glioma in children. Please, Dr. Aurangzeb.
Bismillahirrahmanirrahim. My topic is clinical efficacy of multifraction treatment for brainstem glioma in children. So, brainstem gliomas are uncommon tumors with incidence of about 2% of all the brain tumors. 10 to 20% of brain tumor in children are glioma, with peak age is 7 to 9 years. The treatment of brainstem glioma in children is a great challenge for neurosurgeons. The classification is grade 1, which is pilocytic astrocytoma, and then 2 to grade 4 are infiltrative gliomas like oligodendro, mixed glioma, and glioblastoma. As they are deep-seated brainstem glioma constitute a challenge for neurosurgery, since surgical access is difficult due to the functional importance of this structure. Despite advances and refinements in the microsurgical techniques, some allocant area of brain still remain inaccessible for surgery due to the unacceptable morbidity and mortality. Due to the location of these tumors, the potential risk of biopsy are rarely performed, especially in Pakistan. High morbidity and mortality rates innovative conformal techniques have focused on decreasing the morbidity by limiting the radiation delivered to the surrounding tissues. Among the advanced conformal techniques, gamma knife radiosurgery has gained an increasing important role in the treatment of these tumors. So in our center, neurospinal cancer care, we had 34 brainstem glioma patient children. They were young. The symptoms were within 3 months. The Karnofsky rate status was above 70, and this was confirmed by the MRI. The location, the epicenter is brainstem The male to female ratio was 21/13 and median age was 10. So these are some of the images that were treated, and we can see that there is a considerable regression within 1 to 2 years. And we can see that within 1 to 2 years, patient can have almost completely regressed tumor. As I'm more of a neurosurgeon, so I do not define different fractions, rates. It was done in 5 fractions. So we can see there is a regression in these tumors. The best results were seen in definitely in a low-grade glioma, as Dr. Aftab told yesterday, that high-grade gliomas do not show much of the best results. So the presentation was with headache, cranial nerve palsies, nausea, vomiting, and motor deficit. More of the location was pons, and then followed by midbrain and medulla. So mean tumor volume was 15 centimeter square. The mean dose was 27 gray, and they were done in 5 fractions. The follow-up were planned at every 6 months after the treatment, and patients were evaluated based on their MRI images and clinical status. Partial radiological response was noted in 7 patients. Stable status was seen in 22, and progressive disease was also noted in 5 patients. 12% of patients showed enhanced tumor in MRI that results in shorter overall survival. The median overall survival of patient with enhancing tumor in MRI and non-enhancing were 15 and 52 months respectively. Durable symptomatic clinical improvement was seen in 45% of patients. In 21% patients, there was observed to have radiation complication like headache, dizziness, and nausea. Good conformal and sharp dose fall-off could maximize the dose to the large and minimize the dose to the adjacent structures. Accurate dose delivery to the target and minimal dose to the critical structures such as optic nerve and optic chiasma during the glioma treatment. So due to the edema, about 10 patients, or the tumor size, we had to do the VP shunt in 10 patients. And intra-axial progression, particularly in medulla oblongata, and the swelling difficulty was observed in 12 patients. So different literatures have shown the different results, and they have done the gamma knife radiation even in the high grade, and they have shown good results. And to the tumors, those are resistant to the therapy, the chemotherapeutic drugs can be used, and they have shown good results. In most cases, in our limitation, most cases the biopsy procedures are hard to implement in the study. The pathological type could not be determined for all the cases. The surgical morbidity was not only a negligible issue, but yet molecular and biological characterization of brainstem glioma may provide a new way in the future for making more effective therapeutic regime. These are different articles, although we have published a recent article on brainstem glioma in our studies, and these are again for focal brainstem glioma, which have a good results. So gamma knife represents a reasonably treatment alternative to the either primary or adjuvant in a pediatric population, especially in a low-grade brainstem tumor. More patient number and longer follow-up period are crucial in the assessment of efficacy of gamma knife in future. Thank you. So I would like to ask one question with my panel, as I have a time. एक सवाल तो सर मैं भी पूछ सकता हूँ ना चेंज के लिए. तो मैंने सर वालों की ज़रा ज़्यादा डिटेल नहीं बताया, क्योंकि मैंने कहा मोर ऑफ अ न्यूरोसर्जन, तो मैं उसमें. तो सर आपका कितना रहा है ब्रेन स्टेम के लिए फॉर बायोप्सी, बिकॉज हम तो बहुत लिमिटेड करते हैं विद डॉक्टर आफ्ताब एंड डॉक्टर आबिद सलीम. ज़्यादातर लोग करते हैं तो पेशेंट कॉम्प्लिकेशन में चला जाता है. तो आपका स्टेंस विद डॉक्टर आफ्ताब एंड डॉक्टर आबिद क्या है? Biopsy of brain stem especially.
Actually, patient, when he really comes to us, he has been to 3 doctors, and what they told us that the neurosurgeons have told that it's a futile attempt if you want to do, we can do it, but we cannot guarantee anything. But we get some cases like our Dr. Badarujan here at Dow has done few biopsies, but that doesn't change our thing. Most of them are diffuse gliomas, and we treat them with radiation because there is nothing else that can be done.
Sir, your
Yeah, in my experience, I have done only 2 cases of cavernoma, brainstem cavernoma. So you can diagnose on the imaging, right? And there were 2 cases of glioma, grade 1. They were also operated in India, and they were very young. So there was a recurrence, so I did. So I think stereotactic biopsy is very safe to take from the brainstem. Yeah. Only stereotactic biopsy. Are a good neurosurgeon.
Thank you very much, Dr. Aurangzeb. So your question was very pertinent, that brainstem lesion biopsy is possible or not. In Pakistan, usually we see that most of the patients, they do have the complication after this kind of attempted stereotactic biopsy. So it's very feared, particularly in the pediatric age group. Very few neurosurgeons who are trained in or qualified in pediatric neurosurgery. But I guess this is always an open situation, how you move forward. So thank you very much, Dr. Aurangzeb. So I move forward to invite Dr. Humaira Mahmood. She is a director, Noori Hospital, Noori Cancer Hospital, Islamabad. And I'm grateful to her that she accepted this invitation for this talk in this session. And she will speak about establishment of SRS, SRT in CNS tumors in a LMIC and experience at AECH Noori, Islamabad. Please, madam. Come on stage, I have this. Thank you.
Bismillahirrahmanirrahim. Esteemed neurosurgeons, respected colleagues, Honorable Dr. Shahid Hamid is sitting here, and my dear students, Assalamu alaikum. ये की निकल गई मैंने इसको प्रेस किया अच्छा ठीक है Okay, before I start my presentation, I would like to thank Dr. Azhar and his team for inviting me to talk about how we have established high-precision radiotherapy techniques in resource-constrained settings. And I would be focusing on how we have overcome geographic and financial barriers in establishing stereotactic radiotherapy at Atomic Energy Cancer Hospital, Noori, Islamabad, which is one of IAE anchor centers. You would agree with me that we being lower middle income countries, we always acquire advanced technology later than the developed world. But fortunately, in the field of radiation and oncology, we have seen rapid advancement in terms of both radiation techniques as well as equipment in the last 2 decades. And now there are so many hospitals in the country that are offering high precision techniques to our cancer patients. In fact, stereotactic radiosurgery was brought to Pakistan by Dr. Sattar Hashim and his team, thanks to them, and then other hospitals followed. So at the moment, at Noori, we are providing all the diagnostic and non-surgical treatment modalities under one roof so that our patients don't have to go anywhere, thanks to our former director, Dr. Fahim, and our visionary seniors from Pakistan Atomic Energy Commission. Because we strongly believe that access is not about machines, it's about equity, dignity, and the right to survive. It's a harsh reality that lower middle income countries hold 70% of cancer burden, but only 30% access to radiotherapy. And this gap in access to radiotherapy is translated into gap in survival. And according to International Agency for Research on Cancer, for most of the tumor sites, both the cancer incidence as well as cancer-related mortality are much higher for lower middle income countries as compared to high income countries. And when we talk of Pakistan, although the situation is not that bleak, there are much underprivileged countries besides Pakistan, but the resources available are still not sufficient to cater to our monstrously growing population that has already exceeded 250 million. And our cancer incidence, according to Global Cancer Observatory, it has already exceeded 1.9 million in 2025 and is expected to go beyond 2.2 million in 2030. And for this much cancer burden, at the moment we have got 39 cancer hospitals providing radiation oncology services, mainly centered in the bigger cities of Pakistan. And out of those 39, 19 radiation oncology setups are working under Pakistan Atomic Energy Commission, and Noori is one of those radiation oncology setups. So these are just a few glimpses of Noori Hospital, which is working since 1983. It is situated in the heart of Islamabad, catering a population of more than 18 million. And we have actually shifted from 2D to 3D, then IMRT, VMAT, and then to stereotactic radiation. Currently in Pakistan, there are about 9 or 10 hospitals that are doing stereotactic radiation. And there is echo. Okay. So the common challenges that we face in lower middle income countries include infrastructure deficit, manpower, financial barriers, etc. But we have overcome them with determination, collaboration, and a willingness to adapt and grow. So this is the list of the hospitals that are providing SRS, SRT using different kinds of equipment. I will not go into detail. So just to show you the gravity of cancer burden in our hospital, this number is rising with each passing year. The number of new patients registered has already reached almost 11,000 last year. And the number of follow-up patients has gone to almost 70,000 in 2025. And with this, there is proportionate rise in the number of brain tumors. We see almost 500 to 600 patients with brain tumors in a year. And gliomas are the commonest for both the brain as well as spinal cord. And the commonest age groups involved are from 30 to 39. We even see pediatric patients as well. And brain tumors in our hospital the number is little higher in male patients as compared to female. So you cannot just embark onto complicated radiotherapy techniques without having experience in conventional radiotherapy. So at Noori, when I joined in 1994, we started with 2D radiation, and in 2011 we shifted to 3D, and then gradually. And it was in 22 that we started treating our patients with stereotactic radiotherapy on both CyberKnife as well as TrueBeam Linac. So this is just a diagrammatic representation. So it's not easy to start advanced radiation technique without having a sufficient clinical load or relevant clinical load, as well as training for all the radiation oncology personnel and other technological requirements. So as far as patients are concerned, there is no dearth of patients in terms of variety and number at Noori. And all our radiation oncology personnel, including radiation oncologists, medical physicists, RTTs, as well as biomedical engineers and technicians, they received sufficient training before we were able to start SRS and SRT in the hospital. As stereotactic radiation is delivered in very high doses per fractions, so we need to be quite meticulous right from the imaging and simulation to execution of treatment. So there are a number of technological requirements that were required to be fulfilled before we were able to start this technique. Starting from simulation, for visceral tumors, we are doing 4D simulation. Otherwise, for all the brain tumors, we are doing MR simulation as well as CT simulation, and then we fuse them. And on TPS, there should be fusion capability, both rigid and deformable image registration should be there. On TPS, there should be availability of advanced algorithms, small field dosimetry support, inverse planning, steep dose gradient optimization, and biological dose evaluation, and EQD2 evaluation. And as far as treatment delivery systems are concerned, either you can use linear accelerator with certain specs, including high mechanical stability, small field capability, high dose rate with more than or equivalent to 6,000 monitor units per minute. It should be a flattening free filter beam, then high resolution MLCs should be there, which should be less than or equivalent to 5 millimeter in thickness. Or you can use specialized systems, including CyberKnife, Gamma Knife, and MR-Linac. The image-guided radiation is mandatory. It can be either cone beam CT as we have on TrueBeam, then we have orthogonal imaging, and we do real-time image guidance during execution of treatment on CyberKnife. Then you can also use surface-guided radiotherapy. For positioning accuracy, there should be 6 degrees of couch freedom for the couch. And QAs are very important, not only machine QAs, but patient-specific QAs need to be done for each patient, and it should be end-to-end testing. Then, of course, data management and safety is also very important. So at Noori, we have got this 4D CT simulator, MR simulator, CyberKnife, TrueBeam, Linac, with all those technological requirements that are required, including all the phantom, small field dosimetry, and other QA/QC equipment. And of course, you need to have understanding of radiobiology that I'll not go into detail. Dr. Fawadul Qamar has already described it for all. So this is our 4D CT simulator that we are using for SRS SRT. This is MR simulator. This is our TrueBeam, and this is CyberKnife. So another most important prerequisite was, of course, a financial requirement, and for that, we are really thankful to Planning Commission of Pakistan for providing us enough funds under Public Sector Development Program. And thanks to Dr. Fahim and all our seniors for making efforts in bringing this technology to Noori in Islamabad. Otherwise, our patients initially had to go to Karachi for getting this treatment done. So we have got training at different levels in Turkey, in Switzerland, and also on-site training by application expert. Initially, in the era of COVID, we were given online training as well, but we didn't start stereotactic radiation unless we got on-site training in November 22. We also organized a workshop on small field dosimetry with the help of International Atomic Energy Agency in September 22. Then this was before we started SRS. And recently, our small field dosimetry has been endorsed again by IAEA in October 2025. This is how we started. We started with a young girl with optic nerve glioma who presented with proptosis. She had already undergone surgery twice, and now she presented with second recurrence. So although her vision was not recoverable, but we were able to correct her cosmetic deformity, and she's still coming for follow-up, and she's all right. And then we kept on increasing the number of patients per day. Our contouring time and planning time is also improving day by day. And from November 22 till 31st December 25, we have made 591 plans, and most of these have been delivered in 5 fractions because of their size, their proximity to OARs. And those patients who are apprehensive, who cannot lie down on CyberKnife for 30 to 40 minutes or longer, then those are treated on TrueBeam. So for CNS tumors, most of the patients are usually treated on CyberKnife, but only apprehensive ones are treated on TrueBeam. Otherwise, we treat all the visceral lesions, including liver, lung, pancreatic, prostate, or nodal lesions on TrueBeam for stereotactic radiation. So on CyberKnife, the treatment time is generally 30 to 50 minutes, while it is just 10 to 15 minutes on TrueBeam. So this is just a tabular representation of the number of plans on CyberKnife. And just like now, we have been treating a wide variety of tumors on CyberKnife with SRS and SRT. The commonest ones that we have treated till now are pituitary adenomas, followed by meningiomas, then brain metastasis, vestibular schwannomas, AVMs, and so on and so forth. So on TrueBeam, a smaller number of patients with brain tumors. So selection of patients, again, it is also meticulous, and we decide according to site of the lesion, size of the lesion, number, histopathological diagnosis if it's there, and their proximity to OARs, patient's performance status, expected survival. And we also take into account whether patient has restorable visual and hearing impairment. And of course, patient's apprehension is also important. Informed consent is taken, MRI is done both before and after treatment. We have time? Dr. Okay. So these are the different steps that are involved in stereotactic radiation, starting from patient's referral, clinical assessment. First, MRI is done with 1 millimeter slices, followed by CT simulation with 1 mm slices. Fusion, registration is done, contouring, then of course planning. Plan is always evaluated by a second oncologist and medical physicist before execution. And on the day of treatment, patients are counseled and explained in detail. IV steroids are given 15 to 20 minutes before treatment so as to minimize the risk of radiation-induced edema. Patient is simulated, DRRs are taken and matched, and patients are continuously being monitored during radiation. So for saving OARs, as has already been discussed in detail, we also do the same. We follow the standard guidelines, and besides fractionation, we also do dose painting. For instance, we can reduce the dose to the part of the tumor that is closer to optic pathway or brainstem, and vice versa. So as I've already mentioned, planning time is improving. For brain metastasis, we are always on the fast track. We try to start stereotactic radiation brain mets within a week. But for benign tumors, it usually takes 1 to 2 weeks. So this is just, I've also added here a few examples of the patients treated in our hospital. This is a patient with 2 brain mets. The smaller one was treated with single fraction, and the bigger one was treated with 3 fractions. This is another example of brain metastasis, and this is just showing the response to stereotactic radiation. This is the lesion prior to, on left side it is prior to radiation, and post radiation it has just disappeared. And we see complete responses in brain metastasis even on first MRI that is done 4 to 6 weeks after radiation, though it's slow in benign tumors. This is another slide showing response to radiation. Stereotactic radiation, as you can see the decrease in size at 6 weeks MRI. This is again another example of brain metastasis. This is another one, again showing response in pre and post radiation images. This was a smaller lesion. It was meningioma lying quite superficially away from optic pathway or brainstem, so this was treated with 18 gray single fraction. And this was a bigger one, so it was treated with 27 gray in 3 fractions. This was also a meningioma. And this is metastatic deposit in spine, treated with 25 gray in 5 fractions. So this is a meningioma, again with an ideal location and size, so it was treated with single fraction. This is an example of right-sided trigeminal neuralgia, treated by 80 gray SRS. Then this is pituitary adenoma. So regular follow-up is very important, as we have just started in 22, so we try to keep a close and regular follow-up. Clinical follow-up is usually done in all the patients at 4 to 6 weeks for first visit, and then if gradually interval is increased at 3 monthly or 6 monthly, and first MRI in benign diseases is usually done at 3 to 6 months. Whereas for brain metastasis, we do it at 4 to 6 weeks. So concluding, we have successfully established stereotactic radiotherapy program in CNS tumors and also extracerebral tumors in our hospital. And day by day referral and confidence of referring physicians is improving. And we have not only established it in our hospital, but are also teaching others through fellowships, through different workshops, seminars, etc. And because of the advanced technology, we have been recognized as IAEA Anchor Center for helping other countries that are less privileged. And our staff is determined and they are working extra hours whenever required. And till now, we have got very good results with limited toxicity. In fact, till now, we have done maximum of more than 3-year follow-up and no late toxicity has been seen. So these are just few glimpses of different activities that we have been carried out. We also had fellows from Yemen. There were 6 fellows, 2 radiation oncologists, 2 RTTs, and 2 medical physicists. Each one of them was placed at Nouri by IAEA for 1 month. So just requesting to our foreign guests, you should visit Pakistan that has got so much of beauty, both natural and architecture. Thank you.
Thank you very much, Dr. Humaira, finishing on time and giving a very detailed talk about your establishment of your center. Now I will move forward to invite Dr. Aisha Ahmed. She is a consultant radiation oncologist at CyberKnife Radiosurgery Center, Ghurki Cancer Hospital, Lahore. And she will speak about a precision radiosurgery for trigeminal neuralgia on CyberKnife, insights from Ghurki Teaching Cancer Hospital. Dr. Aisha, please.
Assalamu alaikum. I hope all of you are having a very good morning. Thank you very much, sir, for inviting me over to share my insight over trigeminal neuralgias. And I'm extremely humbled to be amongst all my worthy seniors and my esteemed colleagues. I hope all of you are having a very good day. To start off with the topic of trigeminal neuralgias, we know that trigeminal neuralgia is not only a facial pain, but it is particularly a neurological disease which practically steals the quality of life, dignity, and basic human functions. And thanks to the upcoming techniques of typically the radiosurgical techniques, which provide frameless, non-invasive, durable, and elegant solution to the trigeminal neuralgic pains. To start off with, we know that trigeminal neuralgia, the trigeminal nerve is basically the 4 main nuclei, considering of the mesencephalic nucleus, particularly located in the midbrain, and it is associated with the proprioception. The second one is the principal sensory nucleus, which is particularly located in the pons, and it is associated with fine touch, vibration, and pressure. And this third one is the spinal trigeminal nucleus, particularly located in pons, medulla, and upper cervical cord. And it is also associated with the pain and the temperature control. And the fourth one is the motor nucleus of trigeminal nerve, which is also associated with the branchial motor fibers. And amongst these, the third nucleus, which is the spinal trigeminal nucleus, is the nucleus which is particularly associated with the disorder of pain pathways mediated through the spinal trigeminal neuralgias. And if we talk about the supply, which is the V1, V2, and V3 supply, we know that V1 is basically associated with the supply over the forehead, the scalp, upper lid, and cornea. The V2 division is associated with the lower eyelid, cheek, and upper lip, and the mandibular division, which is the V3 division, it is associated with the lower lip, chin, and mandibular teeth. So coming to the main topic, we know that there are typically 2 types of the trigeminal pains. The first one, which is the classical typical pain, it is paroxysmal electric shock. Particularly, it stays there for a few seconds to few minutes, and it has got pain-free intervals between the attacks. Contrary to it is the atypical trigeminal neuralgias, which is dull, aching, throbbing pain, and it stays there for a longer period of time. And mainly the triggers for the classical trigeminal neuralgias include even a light touch, chewing, wind, cold breeze, or any other trigger like even blowing the mouth or washing the face. So if we talk about which is the most commonly involved division, it is the V2 division, which is the maxillary nerve. And if we talk about the stats, usually the females are thrice as commonly involved in having the trigeminal neuralgias as compared to the male patients. And usually the patients come with the right-sided TGNs more as compared to the left-sided TGNs. So the clinical features of trigeminal neuralgia, we already have discussed it, that there is a shooting, sharp, and bearable pain, and it is definitely exhausting. The main triggers, yet again, include the eating, talking, and any change in temperatures. It is even induced by light touch, bright lights, or chewing. So we usually divide the score grouping, or we score the patient according to the facial pain using the Barrow neurological system, which ranges from 1 to 5, starting with no pain in grade 1 to occasional pain, which is settled on minimal medication. 3 includes some pain but adequately controlled with the medicine. 4 is that the pain is not adequately controlled over a medication, and any of the invasive techniques has to be incorporated for the management of grade 4. And grade 5 is yet again the severe pain, which needs to have a surgical approach or a radiosurgical approach. So this slide depicts the general treatment of trigeminal neuralgias, and yet again we know that now is the time all of us are focusing on the MDT, because the neurologist, the neurosurgeon, the radiation oncologist, and yet again the pain management, all of these people have to have a very keen and important role in the management of patients with trigeminal neuralgias. And conventionally, the treatment starts with the medical management, including the carbamazepine, and it is almost 70 to 80% effective usually in the patients. It then includes the surgical options if it is not settled on medication, which includes the microvascular decompressions or the rhizotomies. And the topic of our interest today is stereotactic radiosurgery, considering the gamma standard, the gold knife, cyber knife, and yet again the LENIC-based radiosurgeries. So this is a graph which is particularly showing the main differences between the 3 main modes of treatment of trigeminal neuralgias. I'll be talking about microvascular decompression in this particular slide. The main point of apprehension and the main point the patient is usually skeptical over is that in extreme of ages, usually the patients cannot tolerate the general anesthesia. So, and usually the complication rate is higher as compared to the radiosurgery, which we are giving through gamma or the cyber knife, which is almost 10 to 15% chances of facial palsy. So considering my experience in typically cyberknife treatment of the patients, I'll be talking about the diagnosis and imaging, the target contouring, dose prescription, rationale for single fractionated treatment, the isodose philosophy, dose constraints, treatment delivery and QA, and outcomes and expectations of treating the trigeminal neuralgias. First of all, if we talk about the diagnosis and imaging registration, we know that MR is the gold standard in the diagnosis and imaging, because it rules out if there is any secondary cause to trigeminal pain, which may be a tumor, usually CP-angle meningiomas or schwannomas or MS plaques. And particularly the MR, typically using the FISTA and the CIS MR, including the subcentimetric accuracy around 1 mm slice fusion is very important. It confirms any sort of the fusion, it rules out any sort of fusion errors. And if the data says that there is almost 10 to 15% of dose uncertainty, even with 1 mm of the fusion errors. So in trigeminal neuralgia, when we're particularly talking about the stereotactic radiosurgery, imaging accuracy is particularly the dose accuracy. So we have to have a very, very good hold on the imaging and co-registration with the CT scan, with the planning CT, obviously, which incorporates all our bony references and dose calculations. So we start off with the SRS contouring and the targeting of the trigeminal nerve, and we particularly target the root entry zone. And the reasons we target that is because there is a transition zone between the central and the peripheral myelin with a relatively higher volume of oligodendrocytes at this point of site, and higher radio sensitivity, and there is an improved pain control rates when we target the root entry zones. So what we do is that we do a rigid MR and CT registration. The target length is 4 to 6 mm, and the foremost and the keen most important role is to save the brainstem because it is typically in the vicinity, even at times less than 3 millimeter away from the target. So as you can see, this is our real-time patient. He was a 25 years old young man from Gujranwala, I think. So we have targeted and we have marked the trigeminal, the root entry zone of the trigeminal nerve, and you can well appreciate that the distance between the contour line and the brainstem is around 4 mm. So this is very crucial in the planning and contouring point of view. So how do the images look on the CT and the FISTA sequence MR? This is particularly the picture of the same patient. So the dose we are prescribing in CyberKnife is 60 gray with a Dmax of 75 gray, and we're using a frameless image-guided modality. And yet again, I would like to say that Gamma Knife still remains the dosimetric gold standard, but with immaculate planning and contouring, and yet again the hands-on experience of the radiation oncologist, we can yet again achieve the similar outcomes with vigorous clinical talent. So Dr. Fawad has already taken us into the details of BED and a single fractionation regime in treating the trigeminal neuralgias. High BED is effective because particularly we are not targeting any sort of tumor. We are not intending at the ablation of the tumor. The intent of SRS in trigeminal neuralgia is basically the neuromodulation. So we need to have an axonal degeneration, the demyelination at the target, and our intent is to disrupt the pain transmission. And why is a single fraction important in treating the trigeminal neuralgias? Because we already know dose or 80 to 90 gray, whatsoever the planning radiation oncologist or the neurosurgeon is planning the dose, we need to incorporate the brainstem cumulative doses because the brainstem cumulative dose would increase if we are going to incorporate the setup margins and setup errors in the subsequent fractionation. And particularly, there is another very important point that if we intend to re-radiate the patient, particularly 2 to 3 years after the primary radiation, and the patient comes again with a recurrent lesion in the or pain. So if we need to re-radiate the patient, usually with a dose of 45 gray, we need to incorporate the previous plans, and we need to see what was the actual dose given to the brainstem in the prior setting. So the crux is that dose must be high enough to cause the focal nerve injury without extending the biological effective dose to the brainstem. So if we talk about the isodose lines and conformity index and gradient index, Gamma Knife yet again holds a upper hand in treating the patients of trigeminal neuralgias with radiosurgery because keep the dose less than 10 gray, cochlea less than 7 gray, 7th, 8th nerve complex less than 10 to 12 gray, the Gazerian ganglia less than 25 gray, and we try to keep that overall dose to the eyes less than 10 gray. So this is the picture from the patient I've shown you earlier. The yellow line is the 80% isodose curve. The blue is the 30% and the cyan is the 20% isodose line. And as the data says that a brainstem should not be intersected with the 20 or the 30% isodose line, so we have made sure that it does not intersect the brainstem. So if we talk about the data of TGN patients in CyberKnife, we practically started treating the trigeminal neuralgia since a year and a half, and till date we have treated around 1,030 patients in total. And if we talk about the trigeminal neuralgia patients, the number have been around 20. And we have seen that female to male ratio has been 35 to almost 65%. Left TGN-sided patients have been around 80% versus 20%. We prescribe the dose which is around 60 gray, and we try to maximize it up to 75 gray with a mean dose of around 67 gray. So what we do is that we do a frameless-based delivery, imaging for the setup. Pre-treatment QA is very important. Delivery is typically shorter. And the patient interaction, because patient is usually awake during the treatment. And a very important subjective point of note to be noticed is laterality, that it is extremely important that whether the patient has come with right or the left-sided TGN, because particularly in 3 to 5% of the patients, they to 8 weeks, the first assessment, and usually and then yet again at 6 months, 1 year, and annually. And the clinical outcomes include the pain controls, which is almost 50% at 1 to 5 years, and most of the patients, around 7 to 80%, come with the favorable outcomes with the BNI of less than 3 at around 6 to 8 months. And if we talk about the sensory complications, the hyposthesia of facial nerve or dysesthesias, because the target is extremely close to the brainstem, and the higher precision, that's okay. The higher precision prescription dose, which is more than 85 grays, associated with the higher number, numbness, but a better pain outcome. So this is a graphical presentation of our patients. We have you can see that 80% of the patients came with the BNI score of 4, and 20% with the BNI score of 5, and a 4-month follow-up showed that patients had around 10% patients were pain-free with no meds, 60% were pain-free, but they were yet on medication, and 30% had good pain control. So the take-home message yet again includes that we need to have a focal targeting over the nerve, and brainstem safety is extremely crucial. Thank you very much.
Thank you very much, Dr. Aisha. I can understand there will be many questions at this point in time, because all the neurosurgeons were unrest seeing the trigeminal neuralgia on CyberKnife. But we will be having a question and open discussion in the tea session. So tea is ready. I request you all to go to the Ambassador 2 for the tea. But I request you all, please come back at 10:45, because we will start the next half of this session sharp at 10:45. Thank you very much. It will be on SBRT and body saber. अब ये इधर देखिए, आपके लिए मैंने लिखा है, आप कर रहे हैं ना इसको, आप पकड़ रहे हैं, ठीक है। अब आपने ये करना है, ये देखिए, नहीं, हाँ आएगा, अभी ये नहीं है, अच्छा, अभी आप फिर नहीं है, इसको हमने उस पर लेने की कोशिश की। So what you can do, you can start with this gentleman, क्योंकि ये मेरे साथ अभी फ़ोन पे है, ईसा को, चलो ठीक है, इसको ऑनलाइन ले सकते हैं, हाँ ठीक है। तो पहले हम डॉक्टर ईसा को लेंगे, मेरे ख्याल में, ठीक है, पहले ये 2 नाम लिख लें। जी जी, मैं एक मिनट। तो डॉक्टर ईसा वुड बी फर्स्ट वन, हाँ, उसके बाद तो अपना कर, मैं अपने फर्स्ट का ईसा सेट नहीं हो रहा, तो ये कर, मैं कर लूँगा सेकंड में, ये जो मर्जी कर, ये जो मर्जी कर। सुंदर आ गई है, अभी आ जाएगी, चाय में आ गई। अच्छा ये देख, कमालुद्दीन बांग्लादेश, बारबी कचारिया नेपाल, जहाँ से ये सारे निकल गए, तो ये 2 पैनलिस्ट कॉल करें। कमालुद्दीन बांग्लादेश, बाबी कचारिया नेपाल। बस ऑनलाइन बस ये आपके लिए मैंने लिखा। डन है?
करने दे तो ना। हाँ यही हो रहा है।
हाँ जी, ये ज़रा लगाएंगे। मेरी प्रेजेंटेशन पहले होगी, इसमें देखें अगर आप सर्च करते हैं।
सर ये है
सेकंड सेशन में है SRS 72, इसमें है अली के नाम से। इसमें ये डालें, वो वाली ओपन कीजिएगा ज़रा, और ये डालें। उसमें से मैंने एक स्लाइड कॉपी करके उसमें डालनी है, और उसके बाद हमने ये वाली डालनी है।
Hello, hello. जी प्रेम साहब नहीं ऑडियो नहीं कैमरा कनेक्शन इससे ज़्यादा नहीं होगा मैं नेट चेक करता हूँ मैं मैं जा ना लंबी क्यों कर रहा है जा बहुत लंबी कर रहा है तू जाओ अच्छा एजेंडे में आज का नहीं है शायद आज का नहीं है अच्छा ये प्री कॉन्फ्रेंस सॉरी दोबारा नेट तो चल रहा है एक मिनट नेट तो बेहतरीन चल रहा है बताओ तुम बताओ जी बताओ सॉरी वन 1915 344 121 पासवर्ड बताओ प्रेम पासवर्ड SHAMA शमा 1 2 3 पक्का नहीं आ रहा पासवर्ड गलत बता रहे हो 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 भाई तुम्हारा कनेक्ट हो गया है तुम्हारा सिस्टम कनेक्ट हो गया है मेरे पास फायदा नहीं है ना लेकिन रिवर्स करना है ना मैं तो ये हाँ एरर आ रहा है हो गया करो आप सिस्टम कनेक्ट करो नहीं अभी नहीं आया मेरे पास ऑप्शन मेरे पास आ रहा कनेक्ट करने का तुम्हारे पास क्यों नहीं आ रहा नहीं आ रहा
Assalamu alaikum, everyone. Can we please have a seat so that we can start the session? Okay, I will. Okay, no. Can we please have a seat, please, all of you? Yeah. So first, I would like to invite some guests to be. So first is Chairperson Dr. Shahid Hamid. He's not there. And can I request our panelist, Dr. Kamaluddin from Bangladesh? And I would like to request Dr. Baibik Acharya from Nepal as well. So thank you all for your attendance. So there is some change in plan for this session. It would be a session on educational course for SBRT. So two of our colleagues from Jordan, they are not able to make it because of their flight cancellation. So we will start with first from our first session, which would be online, and it would be Dr. Isa Muhammad, and he will be talking about one-shot MR clinic for liver cancers. Can we take him online, please? Okay. Dr. Issa, can you hear me? If you can unmute your mic, please. Dr. Issa, can you hear me?
Hello, hello, hello.
Hello? Oh, okay, thank you. I will go ahead and start. Thank you. Okay, do you see my slides? Good morning. Okay, so I will be speaking on one-shot to cure MR-guided ultra-high dose single fraction SBRT for liver metastases. So, okay, do you hear me? And the screen is sharing, but the slides are not. No, it's moving. Okay, thank you. So I will go ahead.
Kindly start your presentation.
Okay. Okay, thank you. So I will be speaking on one-shot to cure MR-guided ultra-high dose single fraction SBRT for liver metastases. You all know that about 50% of patients with solid tumors develop liver metastases, mainly from colorectal, breast, non-small cell lung cancer, and other solid malignancies. Before the SBRT era, these patients received systemic therapy. However, in 2026, there is much growing interest in effective local treatments, such as surgery, invasive local therapies like RFA, TIS, and non-invasive local therapy like stereotactic body radiation therapy. Now, what are the indications for a single fraction SBRT liver metastases? So the first indication is in elderly patients with severe comorbidities or patients who already underwent multiple surgical resections and they don't have enough hepatic reserve to perform more surgical resection, but they have hepatic reserve to proceed with SBRT treatment. It's also
It's also
indicated in
indicated in
unresectable
metastasis because of the tumor location and distribution
within the
within
liver.
the liver.
Also,
Also,
SBRT can be
SBRT can be
combined with
combined with
surgical
surgical
resection
resection
or
or
other
other
invasive
invasive
local
local
therapies.
therapies.
It's also
It's also
indicated in
indicated in
unsuitable
unsuitable
patients for
patients for
invasive
invasive
therapies
therapies
or
or
after
after
failure of
failure of
invasive
invasive
therapies
therapies
as a
as a
salvage
salvage
treatment
treatment
option.
option.
Now, what's
Now, what's
SBRT?
SBRT?
SBRT
SBRT
is
is
highly
highly
conformal
conformal
radiation
radiation
therapy
therapy
technique that
technique
allow
that allow
us to
us to
deliver
deliver
highly
highly
ablative
ablative
radiation
radiation
doses in a
in a
single or
single
a
or a
few
few
number of
number of
fractions under
fractions
image
under
guidance.
image
This
guidance.
technique is
This technique is
non-invasive,
non-invasive,
delivered as
delivered as
outpatient
outpatient
treatment,
treatment,
and
and
associated with
associated
low toxicity
with
and
low
less
toxicity and
interruption
less interruption
of systemic
of
therapy.
systemic therapy.
And the
And the
ideal
ideal
commercially
commercially
available
available
radiotherapy
radiotherapy
treatment
treatment
delivery
delivery
system
system
for ultra-high dose
ultra-high
single
dose single
fraction
fraction
SBRT is the
SBRT is the
MR
MR
LINAC.
LINAC.
With
With
MR
MR
adaptive stereotactic allow us for the safe delivery of higher BED dose to tumor in a single fraction with MRI provides superior visualization of a gross tumor and organs at risk. Also, it's unique for motion quantification. You can adapt your target organs at risk based on the anatomy of the day before commencing with treatment delivery and the real time tracking. Typically, you can see what you treat. You deliver your radiation dose with high precision and accuracy, and this machine also allow you to use novel MR biomarkers that hopefully in the future will let us know how to select appropriate patients for a single fraction. So in the
past,
we
we
did
did excellent match with
3D
CBCT or 4D
CBCT,
CBCT, liver to liver,
but we were not
able
able
to appreciate
the lesion
during
treatment
treatment
delivery.
delivery.
However,
in the era of
MR-guided
MR-guided
radiation
radiation
therapy,
therapy,
you can see and track the lesion that you are targeting online, and you make sure that
the planned treatment is delivered with high precision.
So
in the era of single fraction, we categorize single fraction into three dose levels.
We define
as ultra-high dose single fraction SBRT, high dose single fraction, or moderate dose single fraction. Ultra-high dose single fraction is defined as any single fraction dose with BED greater than 160 to 200 degrees delivered in a single fraction, while high dose single fraction SBRT is delivered as a BED ranging between 100 to 120 degrees delivered in a single fraction, while moderate dose single fraction SBRT is defined as any BED ranging between 40 to 90 degree delivered in a single fraction.
And the
selection of BED basically is based on the tumor location and its proximity to adjacent critical structures, mainly common bile duct, stomach, and other luminal GI like bowel or duodenum. So with ultra-high dose single fraction SBRT, the patient selection is crucial. So you need to select patients older than 18 years, patients with 5 or less oligometastases, 3 or less oligoprogression are eligible, should have excellent performance status, adequate hepatic reserve, and the size of the lesion should be 6 centimeters or less. And when you treat multiple lesions, the cumulative diameter of all lesions should be 10 centimeters or less. And ideally, the lesions should be located 2 cm from luminal GI and common bile duct, and your organ at risk constraints should be achievable. And the life expectancy of your patient should be greater than 6 months, and patients should be able to tolerate MR LINAC treatment and have no contraindication to MRI. One important thing also, you need to coordinate with your medical oncology colleague the best timing of holding systemic therapy during single fraction, especially when you deliver, for example, 38 degree and single fraction. You need to stop anti-VEGF 4 weeks before and after SBRT, and you need to hold, for example, TKIs 2 weeks before and after SBRT, and highly cytotoxic chemotherapy 3 weeks before and after SBRT, and immunotherapy 2 weeks before and after SBRT. So based on the dose of single fraction, you coordinate with your medical oncologist the time to hold systemic therapy during stereotactic treatment. Now, what's the clinical evidence for SBRT? The first trial is SABR-COMET trial that included 99 patients with controlled primary 1 to 5 oligometastases from colorectal, prostate, non-small cell lung cancer, and breast. Eligible patients were randomized to standard of care versus standard of care plus SABR. Median follow-up in this trial was 51 months, and surprisingly, median overall survival was 28 months for standard of care versus 41 months for standard of care plus SABR. Also, 5-year overall survival and median over progression-free survival were doubled with SBRT plus standard of care. And what we learned from this trial is that improvement in local control of liver metastases translated in improved overall survival. So we need to think how to improve local control to improve the survival of patients with liver metastases. Now, if you look at the data of single fraction, this table shows the first 3 rows. Phase 1 to clinical trials for single fraction delivered with moderate dose or high dose SBRT. You can see when your local control is ranging between 70 to 80%, while if you deliver ultra-high dose SBRT with 35 gray to 40 gray in single fraction, the 2-year local control is 100%, and 4-year local control is 97%. So increased radiation dose is associated with improved local control. And if you look at the toxicity with ultra-high dose or high-dose radiation therapy, you see no grade 3 and above treatment-related toxicity. So this treatment is safe and effective. Also, another retrospective single institutional experience were published in the literature. So as you can see, Cook et al. Included 90 patients with 97 liver metastases. Co-authors reported 2-year local control rate of 60% with BED less than 100 versus 90% with BED greater than 100. This was confirmed by other publications. For example, Mahdevan et al. Included 427 patients with 568 liver metastases. You can see that 2-year local control was 60% for BED less than 100 versus 77% for BED greater than 100. So we always should aim to deliver higher BED to improve local control for our patients. And also now, what's the impact of local control? And actually, several studies show that metastasis with SBRT is associated with improved overall survival. Clement et al. Included 388 patients with 500 metastases, mainly to the lung and liver, and reported local control is strongly associated with improved overall survival in patients with colorectal liver metastasis. So improvement in local control is important to improve overall survival. And this was confirmed by Sao et al., for example, who conducted a multi-institutional retrospective review with more than 1,000 patients, more than 1,700 extracranial oligometastases from lung, colorectal, breast, prostate, and head and neck cancer. And they reported 3.6-fold higher risk of death for patients who develop local recurrence, and 2.7-fold higher risk of widespread progression for patients who progressed locally. So local control is very important issue. Now, if you look at other factors that affect local control, one of them is histopathology. Nice paper came from Moffitt Cancer Center. They published on 372 liver metastatic patients with different histopathologies. These were treated with SBRT, and as you can see in the Kaplan-Meier curve, the 2-year local control, for example, for colorectal patients was 59% as compared to 100% for non-colorectal cancer patients, which means that colorectal cancer patients are difficult to treat and you need to escalate your radiation dose with single fraction. Another factor that affects local control is the tumor size. Ristovan et al. Published on 63 lesions, mainly were from colorectal cancer, and as you can see, 2-year local control was 100% for lesions 3 centimeters or less versus 77% for lesions greater than 3 centimeters. So when you have larger tumor size greater than 3 centimeters, think about those escalation whenever possible. Another factor that increases the risk of intrahepatic failure and overall survival is the number of treated lesions. As you can see in this study, the multivariate analysis showed that increased risk of local failure when you treat 2 lesions or more as opposed to 1 lesion. Also, another important factor is pre-SBRT systemic therapy. We know that these patients are heavily pretreated with systemic therapy. And if you compare patients who heavily were pretreated with chemotherapy before SBRT, they have inferior local control compared to patients. We are participating in this international multi-center superiority phase 3 randomized controlled trial, comparing MR-guided SBRT with single fraction, 38 Gray versus 27 Gray. So eligible patients will be adult patients with good performance status, 1 to 3 lesions, 6 centimeters or less. And tumors should be located 2 cm from luminal GI and common bile duct. Patients with oligoprogression from colorectal, pancreas, and head and neck SCC, cervix SCC are eligible to be included in this trial. Patients will be stratified according to the primary tumor type, number of target lesions, size of target lesion, and the previous use of systemic therapy, then will be randomized in 1-to-1 ratio to either 38 Gray in single fraction with ultra-high dose radiation versus 27 Gray in single fraction with high dose radiation therapy. The primary endpoint is local control within the target lesion. The secondary endpoints are progression-free survival, overall survival, distant metastasis, intrahepatic and extrahepatic failure, physician and patient-reported toxicities, and we will look at some imaging biomarkers as well as some translational part of this research, and hopefully this trial will generate personalized SBRT for liver metastasis. These are the participating centers. You can see Jordan among these centers. And we looked at our data. So between 2018 and 2024, we identified 73 colorectal liver metastasis patients who were treated with 100 Gray and above. 1-year local control in our series was 91.3%, and hopefully in the near future, I will report on ultra-high dose radiation therapy from MR-guided radiation treatment. So now I will move to case presentation. This is a 72-year-old gentleman with metastatic colon adenocarcinoma who had surgery for the primary, received palliative chemotherapy, then developed liver metastasis to segment 4B6, underwent resection.
Recording in
He
progress.
developed
Another
another
recurrence in segment 7
7
and referred for radiation therapy with MR-guided treatment. So based on the tumor location and its proximity to critical structures, and this patient was treated off a clinical trial with high-dose radiation therapy, 30 gray in single fraction. This is his MRL simulation. You can see the tumor red. With MR-Linac, GTV is equal to CTV.
Then you add your ITV margin to CTV. You gather this margin actually from 4D CT simulation image and from cine-MRI and cine-MR SIM. So you need to carefully add this margin, and this is actually critical for liver SBRT treatment. Then you add your BTV margin, which is typically 3 to 5 millimeter. Then you contour your adjacent organs at risk based on the anatomy of the day. And these are the dose constraints for single fraction. And once your target meeting the approval criteria and organs at risk constraint within normal meeting the criteria, then you approve the plan, then you go online for a treatment, you repeat everything, you take a new MR image, you check your GTV, you add your ITV and BTV. Then as you can see here, so the stomach before, at the time of CT simulation was representing in the orange, while at the time of a treatment, it's in a blue. So adaptive radiation treatment, when you have a tumor with a close proximity to critical structure, is very crucial. Then you treat, you see what you treat, and as you can see, 3 months post SBRT, there is no evidence of a tumor. So in conclusion, SBRT is highly effective and safe for liver metastasis. ULTRAS is the first international phase 3 randomized clinical trial comparing ultra-high dose versus high-dose MR-guided SBRT in liver metastasis. Results will guide optimal SBRT dosing and may set a new standard of care for patients with liver metastasis. And thank you for your attention.
Thank you very much. I think we'll keep the question answers at the end because of the time. It is an honor for me to introduce our next speaker, Dr. Nadeem Pervez. Dr. Nadeem Pervez is a very senior radiation oncologist, experienced from Canada, Ireland, and currently working in Middle East. He served as radiation oncologist at Cross Cancer Institute and associate professor at University of Alberta. And he has been a lifelong enthusiast of brachytherapy. So it will be very nice to hear his thought about the SBRT in prostate cancer, whether he should ditch his prostate brachytherapy towards SBRT. So Dr. Nadeem Pervez.
Thank you very much, Dr. Fan, for a good introduction. I'm not going to ditch brachytherapy for SBRT. So that's to begin with. The good thing is my topic is not challenging me, because the topic is for the oligometastatic or low burden metastatic disease. So I saved that portion. So brachy is still the best treatment for the localized prostate cancer. Yeah. I want to thank all the organizers of PSCO who invited me, and all the attendees. That's very important and very elegant. Actually, speakers are sitting in this room. I'm really honored and humbled to talk in front of you, and please correct me wherever I am wrong. So to start with my talk, actually the talk is about the non-localized prostate cancer. So to begin sorry, the slides will come. By that time I'll use So actually it is always honor and good to come to the Pakistan and Karachi, the city, which is my city. So this time PSCO is in Karachi, so it was really amazing. And I want to say some people who I want to meet, and I'll meet Dr. So I forgot if your name is Hamid, Dr. Hamid, yes, yes. So Dr. Hamid, I have to meet you after the meeting, so good to see you here. Heard about you a lot, but never met before. And there are people who come across all the way from under the snow, almost close to North Pole. So Dr. Kevin Martel is here from Canada. He traveled long. I think slides may be fixed by now and then. And many more friends, actually. It's really, really pleasure to be in here because see the familiar good faces, to meet them. And I think slide is working. Yes. Sorry about this technical problem. Not working yet. Yes, yes, I will. Okay. So here you go. So, so we start from this slide. So basically, I think I will go back and yes. So basically, I want to we'll talk about the oligometastatic or low burden metastatic prostate cancer. So first thing is that prostate cancer. Sorry, I think is still. I'm trying to move the slides. Okay. So the prostate cancer is the second most common cancer. Everybody knows that. This is nothing new about it. But the important part I want to say that there is a thinking that in our region, prostate cancer is lower incidence than the West. But there are multiple reasons for it. I don't think this is so much true. Partly true, but there are multiple reasons for it. But what I would want to highlight that when we have the diagnosed prostate cancer in our region, they're mostly advanced stage. They're not the early stage. So there is something which it tells me is that the reason we are not detecting them early, they are there. Many of them, they die before diagnosis because we know this dilemma of over-diagnosis, under-diagnosis, over-treatment, under-treatment. So if you put this everything together, so what I can say that because we don't diagnose them early, some of them die without knowing disease. And when we diagnose them, then many are on the advanced stage. So when I moved from Canada, where Kevin Martel is working, and we work in the similar region, same province, I was seeing the most of the cases were low-risk prostate cancer, and really bored with that because everyone in your clinic is full with that. And when I moved to Middle East, it's completely changed the paradigm. The cases which we were talking in Alberta, that these are very interesting cases, advanced, complex, challenging, and those cases were normal here. So my normal level has changed since I moved to Middle East. So now, changing the normal level actually give me a lot of learning and something new which I'll share with you. And I think we all should evolve here. There are lots of studies come from the Western side, and we don't do as many studies from our region. But there are times when we can contribute to the Western region because they have shortage of those cases which we have. So there we should go sometime. So there are multiple reasons that we don't diagnose early or it was not common. One of the things may be because aging of the population is changing. That's in my own mind. We don't have screening. We don't want to pay attention to our health in general. Our wives are not bugging us so much to go for a PSA test. So we need to work on the family more than the patient because men don't pay so much attention. I include myself into that. So with all those reasons that we have that there is, if you see that, there is some increase in the diagnosis of prostate cancer now than before. So that the differences between West and East is actually coming smaller gap. The world is becoming a global village. Everything is on the global level. So I see the changes are coming. With the changes coming, by the time change is not completely implemented, we're going to deal with something which is more locally advanced prostate cancer. So that's so if I say I want to divide them to when it is localized prostate cancer, which is up to high risk, and when it is beyond that, we were calling all of them metastatic disease, even node positiving in pelvis. It doesn't make sense, but those days we don't have such a good technology, and we were not actually trying to go regional. And when it is beyond pelvis or go to the bones or metastatic side, then we call it metastatic disease, and that can be oligometastatic, and there are multiple definitions about that. I'm not going to go into that problem, but beyond oligometastasis called low burden and high burden disease. So multiple studies have come. I don't have to go into all those studies. Time is short, and I just want to give the key messages. So we all know about STAMPEDE, Oriole, STORM, Saber Comet. This is new phase 2 randomized trial. So we think there is we were giving up on them before and now start giving them more radical approach. I wouldn't say that it's not radical treatment, but the approach is radical, and it does work for them some as radical. So I just put one graph from all those studies, which is Saber Comet trial, and here I want to highlight that if you look at this 20% of the people who actually long-term survivor. So what I can say that I understand that it may not be curative, for all of them, but they have better progression-free survival for the others, 80%, and 20% may have long-term survival. So if we are treating 10 patients and 20 of them, so 2 of them would be long-term survival, it's still worth it to get that approach. And rest 8 will get the progression-free survival. So there is an advantage getting that approach. So that is not new. We know that is happening. And there is actually this umbrella analysis of 21 meta-analysis studies was done, and the conclusion was not different. It says the same, that as using the SBRT technique or getting a radical approach, it actually improved the biochemical progression-free survival. So I want to just mention this study of one of my friends, Tamim Niazi from McGill University in Montreal, where he did this PCS9 study where approach is not much different from others, and this very recently presented in ASCO. If you look at that, even the 20% which I show you in the previous study, it's now going close to 30% or even more. So there are actually improvement in the medical oncology side and radiation oncology side. So not only machine technique and doses are changing, but also changes in the systemic treatment. And this study reflects that after Saber Comet, that this study is showing higher outcome because we have better combination. So I'm just trying to build that, what we're going to talk next. So what we're going to talk next is actually our own experience in Oman while I was in Sultan Qaboos University, and there are my couple of colleagues sitting in this room, and they were witness for that we start looking into beyond oligometastasis. So we know that approach radical, but what we did is actually we treated them with the radical approach, so that is beyond oligometastasis. So the point I'm trying to make here in this 15-minute short talk is that we should not give up. Now, any patient walk into my clinic, if they're prostate cancer, even if they're metastatic, I only have to rule out some patient through MDT if they're really high burden disease or high volume disease that where we cannot go for radical approach, we'll try to go for everybody else for the radical approach. So that's the one important message I want to discuss. So these were our patients. So we reported that, and you saw that in the Red Journal snap, the screenshot I shared that was an oral presentation in Astro, where we presented our results, and a couple of the people involved with me in the study were known to all of you in Pakistan. So we were 24 patients we treated, quite locally advanced or metastatic disease. They were with high PSA. Fortunately, we have PSMA PET scan. We have all type of systemic treatment. So most of them they have their PSMA PET scan before any treatment started. And then when we started treatment was the systemic duo hormone treatment, and we give for radiation treatment. I use our own dose from Alberta, where Dr. Kevin Martel knows that we did a CHARP study, 68 gray in 25 fraction, which actually started from us. I was fortunate to be the PI of the study, and we used the same dose and treated them to all gross disease in the pelvis to that dose as a radical approach. And if there was an other metastatic disease, if it is in the para-aortic lymph node, we go 60 gray in 25 fraction, same time, SIB technique, and if it is the bony metastasis, we're treating them with SBRT, with the usual doses of SBRT. So using that approach, we actually almost treated everybody with the radical approach. In the beginning, our medical oncology was not so convinced by the treatment, and they were claiming that all the benefit is coming from the DO hormone treatment and nothing from radiation. However, with time, they convinced so much that some of the high burden diseases have to tell them, no, please don't go for radical approach. So we were able to convince that colleague, and because there were patients who never agreed for DO hormone treatment, and we treated them with only our technique and with LHRH, and they did so as well as the other ones. So I don't want you to go through all these results in here. I will summarize that in the 2-year plus assessment. I hope that I show you one of the plan. So this is one patient example who almost have 19 metastatic site, and we treated them all with radical approach. Our worry will be that if we're treating so much volume with so much dose, would that be toxic to patient? And that wasn't. So in this patient, we got only our usual grade 2 urinary toxicity. And I did not include all his treatment site, but that with this treatment, he was 46-year-old. I met him last before leaving Oman, was he 4 years after treatment, and his PSA was undetectable. So it is not about one case, so we're talking about overall 24 cases, because one odd case can do better, but that would not change your practice. So with this, with this odd follow-up, and I have those results of the PSA. So what we find is that we repeated the PSA hepatic scan to every patient after a certain time. And if you look into there is metabolic complete response there in many patients, but not about, I think it was 85 or 80% or 75% people, I don't exactly remember. But that metabolic response and the others have the PSA response, biochemical free survival response, PSA was undetectable in 75% of the patient. That I haven't seen typically in this group of patients with the systemic treatment alone. And with this radical approach, we reached to that level. The highest PSA we recorded in any patient was 0.19. And when we submitted our data to the ASTRO meeting, my specialist was saying, at least add one patient who was neuroendocrine tumor, so people will believe our result because he failed and progressed. I said, well, it's not adenocarcinoma. She said, no, but the people will not believe this result. So anyway, I said, well, this is what it is. So we're going to analyze in longer term, maybe after a year or 2 years, so then we can prove the principle. So it worked really, really well for those patients. Their PSA, their metabolic response, their quality of life, toxicity-wise, all possible. So this is my main message here, that don't give up on prostate cancer even if they are metastatic disease. The only thing I would not say that to be too enthusiastic that go to the high burden disease, but my medical oncologists are now in Oman. They actually treated one locally advanced disease, which were like football size of pelvic lymph node. We treated them radical because of the pressure of them. After 6 months of hormone treatment, we reported as a case report. That is a case report. It was very interesting that we converted them completely believing radiation more than us even. So with that, what we decided to move on to some phase 2 randomized trial, a short trial, and I opened that study in Oman before I left. And I think they're accruing on this trial now. We call it OptimRT, and we're trying to test ultra hypofractionation and moderate hypofractionation in metastatic patient with the duo hormone treatment. And then, with this, I would be closing my study, my talk, and the main aim is that main point I want to convey to you is that don't give up on those patients and try to treat them as radical as possible, because that's the more in number we'll see in our region. So it's not that you're going to see more early stages, and we should then treat them as possible, radical one. So these are all conclusion points are same as we discussed. And I just want to take a quick minute from you that we are doing a meeting called AMSTRO in Dubai, and that's be 2 weeks from now. And actually many people here are attendees or a speaker in that meeting. And if you can, it's a hybrid meeting which you can do virtual attendance as well. In person is, of course, will be encouraged. And if you see a lot of stars are coming to that meeting from ISTRO, ASTRO, IAEA, UICC, AAPM, you can name anyone. This all will be coming in that place. It's a good opportunity for all of us to have that interaction if you come in person. If you cannot, it's free registration. You can actually register yourself online and attend virtually. I understand there are visa issues and other challenges. Thank you very much.
Thank you, Dr. Nadeem. Excellent talk. So my next speaker would be Dr. Sundar Siaya, who is working as a clinical oncologist at University Hospital, Birmingham. And she would be talking about role of SABR for central lung tumor, basically, which was 5 years back used to be called no-fly zone, but now we can fly safely.
Thank you. I hope that I can convince everybody that we can have a safe flight now. Assalamu alaikum, everyone. I'm Sundar Siaya. Very pleased to be here. Slightly jet-lagged, but never mind. I'm going to be sharing our experience of lung SABR at University Hospital, Birmingham. I don't know if you are aware. I mean, obviously, I was just speaking to one of their esteemed colleagues in US. It was very commonly used, but for UK, obviously, we had challenges with funding and all, and it was only up until 2013 to 2015 that commissioning through evaluation criteria came through lobbying by Nick Van Ass with David Cameron at the time, and we started doing SABR. So these are my disclosures. So for early stage lung cancer, surgery has always been thought to be curative, but it was often unsuitable for a lot of patients. Lung cancer has got a substantial burden with nearly 2.5 million new cases and still very substantial deaths. 5-year survival rate is still just about 10 to 33% across all stages. SABR has taken a central role in the current climate, with curative intent, achieving very high local controls and generally acceptable toxicity. Within UK, we are very much guided by the SABR Consortium guidelines for the SABR dose and fractionation. And obviously, we have to take into consideration proximity to the target with the central structures. Since 2013, this is the real-world data at University Hospitals Birmingham. You can see the graph. We are the highest delivery center within West Midlands and now nationally as well, particularly with regards to liver SABR and with brain metastases as well. For the extracranial patients, this is our CyberKnife machine data, by the way, so the Linux numbers are not included in this, but you can see there was a surge, and now it has kind of plateaued slightly. Because of the size of the tumor, we are actually treating more on the Linux rather than the CyberKnife. For the central lung SABR, early studies showed increased toxicity, particularly as compared to the peripheral tumors. It was the Timmerman data in 2007, which delivered 60 to 66 grain and 3 fractions. Hilar and pericentral tumors were shown to have at least 11 times increased risk of severe toxicity compared to peripheral tumors. The location was thought to be a very strong predictor of grade 3 to 5 toxicity, and 2-year freedom from severe toxicity was 83% for the peripheral tumors versus 54% with the perihilar and central tumors. It was 4 to 6 deaths from toxicity reported, and then obviously the concept of the no-fly zone was very strictly started to be adhered to. We're just going to remind ourselves quickly for the audience about the central and the ultracentral tumors. So the most common definition that we use is the RTOG definition, which is tumor within 2 centimeters radius in all directions from the proximal bronchial tree. So you take the trachea, carina, right, left, and main stem bronchi. And the other definitions is within 2 centimeters of the mediastinal and critical structures, bronchi, esophagus, heart, major vessels. And I still remember about 10 years ago sitting with our radiologist, and we used to kind of, teach them and say, can you just, show us sagittals, and, we have to measure the distances. So we were very, very stringent on those criteria. Ultracentral, more recent term. There's no consensus definition. It is quite varied by the study, but most generally we are now following the Sunset trial definition, which is that the PTV touches or overlaps the central bronchial tree, esophagus, pulmonary artery, or pulmonary vein, which is obviously at risk of serious toxicity. We are all very, very familiar with these graphs. Locally at our center, we obviously have this dosimetric sheet. We have some mandatory constraints and some optimal constraints, and we divide them by 3, 5, and 8 fractions. We have been using the LungTech trial organ at-risk constraints mostly, but as with the new data coming along, we update this according to SABR consortium guidelines. So just wanted to talk about the RTOG 813 trial. So this was a phase 1 to 2 study that determined the maximum tolerated dose, the efficacy and toxicity for the central tumors. There were 120 patients recruited, and the central tumors were defined as within or touching the 2 centimeter zone around the proximal bronchial tree or immediately adjacent to mediastinal or pericardial pleura. No tumors larger than 5 centimeters were included, and more importantly, 17% of the patients actually did have ultracentral tumors. So though they dose escalated 5 fractions SABR to a schedule of 10 to 12 gray per fraction, starting at 50 and then stopping at 60 gray. The maximum tolerated dose was about 12 gray per fraction, and the probability of dose-limiting toxicity was taken at 7.2%. Now, most importantly, a total of 5 patients did experience dose-limiting toxicity with 1 death, 5 having grade 5, have had grade 5 sinus bradycardia, 1 grade 3 hypoxia, 1 grade 3 pneumonitis, and 1 grade 3 pleural diffusion. However, the 2-year local control in the 57.5 gray cohort was just about 89.4%, and in 60 gray cohort was 87.9%. The overall survival was impressive in this group of patients with 67.9% 2-year survival, and overall survival, and 72.7%, this was local control. Then there was another study from Washington that enrolled 74 patients, 23 patients to phase 1 and 51 patients to phase 2. These were also central and ultracentral tumors, and they defined this again with the tumors touching within the no-fly zone and touching the proximal bronchial tree, but also within 5 millimeter or invading the mediastinal pleura or even the parietal pericardium. Their tumor definition was slightly more generous. They took on patients with tumors up to 7 centimeters or less, and then they had a second dose of 55 gray and 5 fractions as well. They reported their acute toxicities about 6% and late toxicities with grade 3 cardiac or pulmonary in 27% of the patients, grade 4 toxicities in 12% of the patients, and 1 patient died of grade 5 toxicity. Their 2-year local control was 85%, using 55 gray and 5 fractions, and 2-year overall survival to be 43%. So generally speaking, for central tumors, not talking about ultracentral at the moment, so for central tumors within the US, you're going to be seeing doses around 50 to 55 gray and 5 fractions where you feel comfortable with. In Europe and Canada, we are more comfortable with slightly longer fractionation, 60 gray and 8 fractions. And in the RTOG 0813 trial, they use 48 gray in 4 fractions to about 60 gray in 5 fractions. But it is actually a trade-off between your organs and risk structures and your physicist, to be honest. You can start off with 60 gray, you can drop it off to 48 gray, and you really are trying to achieve the highest dose with minimal toxicity. So essentially, we started doing central tumors since about 2010. I have to say we have now become more braver. Our physics team is absolutely awesome. They give us plans and you're like, God, I never thought that you could do it. So we have been taking on more and more patients, and we thought it was time for us to actually revisit our data. So essentially, we looked at the effect of tumor centrality on acute toxicity. We used the same definitions, and basically it was to determine whether or not greater toxicity is observed whether treating more central lung tumors. What we did was we collected the data for 200 lung patients at the baseline, and post-toxicity, CTC-AE toxicity assessment was done. Because it was a retrospective study, obviously it was a bit challenging, so we decided that we're going to record the change in toxicity and measure it relative to the baseline assessment. We set the structures from the Ray Station and Propel, and we calculated the distance from the no-fly zone and proximal bronchial tree to the edge of the PTV. And then we did significance testing using the Fisher-Zigzag test. So this is a method that we used. So the structures were converted into a 1 millimeter cube binary image, and then we measured the distance from each voxel to the nearest point of the PTV, and then we calculated that from the organs at risk. So these are our results. In approximately 20% of the cases, the PTV volume overlapped with the no-fly zone to some extent. So here you can see the number of cases on the horizontal plot and the distance to the no-fly zone. So you can see that some of the cases we were treating within a centimeter to the central structures. We defined toxicity as to where the post-treatment toxicity score was worse than the baseline. No toxicity was defined where the score was less or the same. So we took 6 parameters: cough, sputum production, dyspnea, appetite, dyspepsia, and fatigue. We reported toxicity in 13.4% of the cases with cough. Sputum was about 5.7%, worsening sputum production. Dyspnea, 5.2%. But the highest rate was of that of fatigue. 70% of the patients did report fatigue, and I didn't have time to present the whole of the CDC criteria, grading and all of that, but essentially it was grade 3 to 4 fatigue that was reported. When we looked at the no-fly zone, so essentially what we did then was went back and looked at whether the high dose area was correlated to this toxicity, and we found that actually there was no correlation of the high dose to any of the toxicities that we have seen. Obviously, our numbers are small, but we then did a dose response analysis, and we showed that the maximum dose to the no-fly zone and the proximal bronchial tree for the cases where coughing became worse was unchanged and improved was no different. So we did quite detailed analysis of that, and now we are collecting prospective data for this as well. We also then looked at proximity to the proximal bronchial tree to these parameters, and we noted that again, even when your tumor was within 10 millimeters, and as you know with SABR you can have high hotspots of up to 120% or even higher, that it did not correlate to your toxicity. So in none of the comparisons that we had, we found that there was no significant difference between the overlapping and the non-overlapping cases. Considering the low number of toxicities and large number of cases are needed actually to resolve any effect. The literature on treating the central zone is obviously quite mixed. In 2011, Hasbeck found that 60 and 8 scheme was quite well tolerated, but obviously others found significant toxicity. Our personal experience is that of safety, and we are actually taking on more and more central tumors. Our preliminary look at the maximum doses to the volumes did not suggest a strong dose response either. So overall, the toxicities appeared to be very low. Only cough and fatigue were worse in more than 5% of the patients post-treatment. They didn't appear to be worse when treating in the central zone. Usually, we were treating these to a lower dose of 60 and 8 fractions rather than 55 in 5 or 54 gray in 3 fractions. We have not yet looked at whether it matters how far into the no-fly zone the PTV extends to, but we are actually looking into data. But you have to imagine that the problem is that when you are actually looking at voxel by voxel, that it becomes extremely challenging to then draw any conclusions, and the data bins are very, very heavy to work with. Obviously, we need a much larger number of cases. So I think anyone in the room that has got experience, we'd be more than happy to collaborate to try and get together a series. It'd be really nice to learn from you all as well. Obviously, investigations into the applicability of the SABR for the UC lung lesions treatment is on the rise, and further investigations incorporating the long-term follow-up of post-survival. And we obviously need prospective data collection that is needed to establish significant clinical correlation with identified dosimetric advantages. Just going to highlight here other stable lung considerations. Obviously, there is now more talk about ultra-central lung lesions because now we have developed that comfort zone within the central lung lesions and the interstitial lung disease, so ILD. Obviously, Aspire ILD trial came out. Again, we had questions from our respiratory physicians, why aren't you taking these patients on? And I have to just kind of point out, particularly to our younger fellows here, that, you do see significant toxicity up to 35%. I personally have had a death in an ILD patient, so you have to be very careful, make sure that you've adequately counseled the patient, you've looked at the GAP scores. And I just wanted to kind of highlight a paper that we've literally just published last month, where we've looked at our toxicity and outcomes in the ILD patients. And we were actually very fortunate that pretty much all the patients we discussed with Dr. Palmer in Canada, so he was kind of involved in us treating this. And then obviously look out for the Sunset trial. It's a multi-center phase 1 dose-finding study to determine the maximum tolerated dose for the ultracentral lesion. So we are getting braver and braver, and I think it's time that we all collaborate together and learn from each other. Thank you.
Thank you very much, Dr. Sundas. We'll have questions at the end. It's my pleasure, and I feel very proud to introduce our young rising star from Pakistan, Dr. Muhammad Ali. He trained in Shaukat Khanum before. He's a radiation oncologist in Peter Mac in Australia, and Icon Cancer Center. His main area of interest is GU cancer, head and neck cancers. And his research is on SBRT for primary kidney and metastatic cancers. He's steering committee member of TROG Genitourinary Group and IROC, which is the International Radiosurgery Consortium for Kidney Cancer. And he has recently published an international consensus guideline on kidney SBRT. So he's going to educate us about that.
Enable content. It's just stuck there. What is happening? Location is used by Zoom meeting. Can we cancel the Zoom meeting? Sorry, some technical issues, but thanks to Dr. Rana Irfan for the kind invitation. And thanks to Azhar Bhai for the kind invitation to be here. And it's also a great honor for me. I have presented at quite a few conferences, but having Dr. Shahid as one of the among the audience, so it's really a great player. He's our lifelong boss and mentor. So we have learned a lot from him, not only medical radiation oncology, but being as a good mentor in helping the young generation to grow as well. So I would be talking about role of SABR for primary renal cell carcinoma. So no disclosures, excuse me. So if we look at the incidence of kidney cancer, so over the last 3 decades, the incidence of kidney cancer has significantly increased. And in the recent published data, it is among the top 5 cancer burden worldwide. And the most common group is 70 plus years of age, which has multiple other medical issues which make the treatment quite challenging. At the time, the current standard of care is surgery, where partial nephrectomy is always the preferred option. But again, like older age populations, the surgery is not always possible. So in these situations, it could be quite challenging, and we have a very limited options available as a radical intent treatment. And one such treatment is thermal ablation, which is a topic of social media, quite being portrayed in Punjab particularly. So thermal ablation, we can do it, but it has a limited efficacy, particularly for tumors which are more than 3 centimeters. And in very few cases with up till 4 centimeters, we can consider cryoablation. And with more than 4 centimeters, the incidence of complications quite significantly increase, but at the same time, the efficacy decrease as well, with local failure ranging as 10 to 20%. Compared to these, if we look at stereotactic ablative radiation, so all these challenging situations where we can't have thermal ablation or surgery, particularly larger tumors, perihilar tumors, we can consider SABR. And SABR has get another extra green tick being non-invasive and outpatient treatment, which have a very minimal impact on the quality of life patient as well. So what is the evidence we have so far, so which give us the idea that SABR can be considered as a treatment option? So far we have multiple small phase 2 trials, which are basically, if you look at the number of patients column, it is a very, very small number of patients, and that is one of the criticism for stereotactic radiation as well. But if we compare it with the thermal ablation, which is considered as a guideline endorsed treatment, so we don't have, to date, we don't have any single prospective data for thermal ablation. And all the data is for tumors with median tumor size of 2 to 3 centimeters. And if we compare, though we have small number of patients in SABR trial, the outcomes for treating tumors which are more than 4 centimeters are identical to thermal ablation. And renal function preservation, which is the primary outcome for small renal masses, because most of the patients, they don't die of their cancer, they die of other medical issues. So it is comparable with the partial nephrectomy. So to date, the largest data is from Peter Mac, which was like Peter Mac-led trial, which was multi-institutional trial, 26 grade single fraction or 42 grade 3 fractions. So in this trial, we enrolled 70 patients. The median age was 77, so it's a quite older age group. And if we look at the median tumor size in the both cohorts, it was 46 millimeters, which is quite significantly larger than the recommended thermal ablation. And another thing in this cohort, one other option is active surveillance and watchful waiting. So 2/3 of the patients has already progressed on active surveillance and monitoring, and they were having a growth quite significant, which warrant further treatment. So at a So at a median follow-up of 43 months, we reported the initial outcomes. There was only 7 grade 3 adverse events, most common fatigue, and 2 patients had colonic stenosis, and they required surgical intervention for it. But overall, throughout the trial follow-up, there was no local failure, and as expected, no cancer-related death as well, because most of the patients were T1 disease. And if we look at the kidney function decline, it was acceptable, and out of 70, only 1 patient required dialysis. Though this is the prospective trial with the largest and the longest follow-up, 43 months, but still in oncology, it's considered as a low one. So we don't have so far any published data in a prospective space. But we have reported a retrospective individual patient meta-analysis from international 12 institutes, 190 patients. And in this one, we have found cancer-specific survival of 92%, and the local failure and distant failure of 5 and 10% respectively. So here we can see that compared to Fast Track 2, where we have 100% local control and cancer-specific survival, there are slightly more failure and more cancer-related death, because in this analysis, there was more grade 2, stage 2 or stage 3 patients as well, and the dose limitation was the main issue. Some of the centers use dose as low as 24 in 3, which is quite significantly lower compared to 26 in 1 or 42 in 3. So we have recently submitted long-term data from Fast Track 2 with median follow-up of more than 6 years. So currently, It is under review at Lancet, so we just had a feedback from the reviewers. We are working on it, and hopefully we expect it would be published by April. Another thing, as being a medical oncologist, you must know that clear and non-clear cell histology, their response to systemic treatment is quite different, and it is because of different molecular profile. But giving a higher dose per fraction, we can overcome this inherent different in sensitivity. And we have reported clear and non-clear cell carcinoma. They have the similar outcomes in terms of local control, distant spread, or the cancer-specific survival as well. So in localized kidney cancer, you can give radiation for non-clear or clear both. Solitary kidney is always a challenge. The most important thing, because in solitary kidney, the patient is at stake of dialysis. So our aim is to maximize the control of cancer. But in order to avoid or delay the need for dialysis, we should think about more nephron-sparing options. So surgery definitely remains the standard of care, with partial nephrectomy the preferred approach. But we have found from IROC analysis, irrespective of solitary or dual kidney, there is no difference in terms of cancer-specific survival, local control, or the progression-free survival. But number of patients for solitary kidney was low. It was 56. But even then, we can find that we can provide them a good local control. And the important thing is the kidney function. So the difference in 2-year decline from baseline was acceptable, around 10 ml. And the most important thing, the dialysis rate, it was almost identical in both cohorts and less than 4% in both patients. And the patients who had required dialysis, they were the one with baseline median GFR of around 30. So any patients with GFR of around 30, they are at high risk of dialysis. And we encourage to always link them in with the nephrologist and counsel them in for high risk of dialysis as well. So some key practical tips. So we have just, if we look at the current guidelines, so it was never endorsed by the guideline. This is the first time that in version 1, 2026 NCCN, we had made our way up to the main flow charts. And kidney saver is considered as an option for stage 1 tumors and selective stage 2 and stage 3 tumor as well. So due to time limitation, I will not go into detail, but this is just last night I had the email that the contouring guideline is in Red Journal in press, so you can read it. These are two good documents which were just published, and it's still in press. So it's a good from clinic to follow up. You can read it, and it can give you a good guide of how to select patient and how to follow up them as well. Some important thing, the most important thing is kidney being a respiratory organ moves with respiration. The average displacement is around 7 millimeter, but in certain tumors you can have as much as almost like 2-3 centimeter motion as well. And this is one of the case you can see that by advanced breathing management from free breathing to breath hold, we can reduce the GTV to almost half. And why it is important for reducing the PTV or GTV volume? Because from our data, what we have found, that if we look at the green lines and the disappearance of that black, which is the nuclear contrast, which is taken up by the kidney parenchyma, over time, you can see in the both diagram above and below, there is a gradual decline, and that corresponds to the green line, which is a 50% isodose line. So by reducing the PTV volume, we are reducing the normal parenchyma from higher dose region, and that helps us to preserve more renal function. So that's why if you want to do kidney saver, make sure that you have a advanced motion management in place. Another thing is important clinical tip if you are doing saver for lung, pancreas, or liver, don't rely on average or maximum intensity projection. Always go through individual respiratory phases. This is one of the tumor. You can see the green one is the one which was controlled based on just average and MIP. But when we looked at entire phases, you can see the red one, the tumor was obviously under control. And it's not only for the primary target, it's also important for the organ at risk, particularly in the high dose gradient. Again, the small bowel in orange, you can see it was based on average, but on the axial faces, it was coming in contact with the PTV. So don't only look for the primary tumor, always look at the high risk organs like small bowel, large bowel, and stomach as well. And this patient we did with the breath hold, and with breath hold we can see that we can reduce the motion of small bowel, and it is not coming in contact with the primary target. This is a good document to follow. That is the protocol Fast Track 2. It's available free access, and it contains entire quite comprehensive description about the dose planning and the dose constraints as well. These are our departmental protocol. We do less than 4 and sometime up till 5 centimeter single fraction. For larger tumor, we go with 3 fractions. Some certain, mostly in USA, they go with 5 fractions. Coverage is important, but in certain situations, you can accept under coverage if you are not able to meet your OAR constraint. We are a clinic-based center, so we prescribe at 70 to 90%, and our hotspot is normally 125 to 140%. And the other important thing is always the low-dose wash, but in kidney, it depends on case to case. So you will never get a good-looking low-dose isodoses, which we see in the liver or even in the lung. The reason being, kidney is surrounded by the small and large bowel lobes. So in larger tumors, always prioritize your targets. Always the aim is to give maximum dose to the target, but preserve the renal function, as you can see from the arrows in this group. But always look at the low dose washout as well. In larger tumors, we accept a bit higher dose toward the small and large bowel, and it is at the expense of accepting a bit higher toxicity compared to the other. And these plants we call them as a ugly looking saber plant because it doesn't give you a very conformal round looking curves which we see in the peripheral or sometimes in central lung tumor as well. But in tumors which are small, in those situations, you don't need to give extra spillage of low dose. So in this case, like you can see, the low dose is going across the small bowel, but with the improved plan, you can push it back. So don't be on our patient population. If we have some technology, it comes with a responsibility. Make sure that you're doing something interesting and new, which can help to improve the standard of our care. And the last one, I would just like to say some words about Dr. Arif Jamshed, and good friend, good mentor. So we first met him in 2007, so we were lucky to have him as our supervisor, and me, Waqas, and Irfan were his first 3 residents. And since then, he was like as a teacher, supervisor, then mentor, and then eventually for last 5 years, we have seen a totally different side of him, and he was a very good friend. And whenever we are with him, we feel as if he is of our age group, and we really, really miss him. I wish he would have been here. So I would humbly request all of you, please keep him in your prayers. And that's it. That's life, and we have to continue to live them. Thank you very much. So I think we are already running late, so I will request if we can move to the next hall for the US POC symposium, please. It's in the same? Oh, okay, don't move, please.
Next phase of mind.
I can move.
Yeah. So you'll pull those up or I'll pull it up? The slides that I need, are you going to pull them up or I'll pull them up? So Quinn Lee is the first one. But first one will be this one.
Video? Okay.
Yeah, but don't start it yet.
Yeah.
And then I need this up and just available. I'll introduce some people.
वीडियो लाइनअप कर लिए
Video is the first one. See? That's me first. Yeah, that slide is just the speaker's slide.
Okay, you're moderating as well.
I'm moderating. I'm moderating, and that's the first slide I need right now. And then this will be the first talk. Okay. The second after that is going to be the link. Is going to be live.
Mansoor Ahmed, right?
Mansoor Ahmad. Yeah. And then the very last will be one more talk, which is Khurram.
I've got that.
Yeah, we'll be in a second. Yeah, I'll start here. Okay. Okay, can I get started? Assalamu alaikum. So I think we want to get started with this next section because we don't want. But the picture is important. Okay. So we want to get started with this next section because we don't want to run into Jummah. The next section is called Radiotherapy as an Immunomodulating Agent. Sorry. So it's appropriate that we ended the last slide with Michael Jordan from Chicago. I'm coming to you from Chicago. There's a couple of people that have come from outside. We are part of this U.S. Pakistani Oncology Working Group. And the purpose is we have two sessions. One is today, now. One will be tomorrow. We're trying to bring some outside speakers from the U.S. mostly, that will try to engage with you. So this first session, we are trying to bring a newish topic to introduce to you and give you some background. The background is some biology, some clinical studies, things for your consideration to see if there's a role for that here in Pakistan. We have 4 speakers, inshallah. I'll introduce them briefly. It'll be interesting because the first speaker is going to be online. The second speaker, unfortunately, could not make it because of government issues with the NIH, but I'll mention that as well. The third speaker will be here in person, so we'll have one of every type. So the first speaker is Quinn Lee. She is the Catherine Dexter McCormick and Stanley McCormick Memorial Professor, and she's the chair of radiation oncology at Stanford. She has a head and neck focus. She's been in charge of the head and neck section of the NRG, the National Trials Group that we have for the last 10 years, and she's the co-president of the NRG right now. So we're trying to bring somebody here that can talk about trials for you all. This past year, she is the 2025 Astro Gold Medalist. So, and she's a woman in science as well. So she will be giving a talk. She's currently at the NRG, but she still agreed to do this for Pakistan because she thinks it's very important. So she pre-recorded her talk. So I will introduce her here, and we can start that. Okay.
कर दें प्रेम आ रहा है यार प्रेम क्यों नहीं आ रहा नहीं आ रहा मिक्स पे नहीं आ रहा लेकिन किस पे क्या होगा
ऑडियो ही नहीं आ रही है ना इसमें
उस पे चला दो डायरेक्ट वीएलसी पे चला दो छोड़ दो फ्रेम छोड़ दो वीएलसी पे चला दो दूसरी विंडो पे ले जाओ छोड़ दो फ्रेम वीएलसी अभी भी नहीं आई
हटा दो
बकरा दो बकरा है कितने लोग बकरा दो
कौन सी ब्रांड भी
चला दो वीएलसी भी चला दो मान लो बात
वही चल रहा हूँ
ये रहा ना ओपन विथ इसी पे रहने डुप्लीकेट कर दो
Good afternoon. My name is Quinn Lay. I'm from the Department of Radiation Oncology at Stanford. Good afternoon. My name is Quinn Lay. I'm from the Department of Radiation Oncology at Stanford University. I'm also the Energy Oncology Group Chair. I've been asked to talk about the relationship of radiation and immune checkpoint inhibitors, for which I'm going to say ICI for short. These are my disclosures over my entire professional career. The discovery of immune checkpoint therapy, especially those that inhibit the PD-1 and PD-L1 pathway, have really revolutionized the management of solid tumors. And listed here for you just a snippet of the FDA approvals of these agents in recurrent metastatic setting in either the first or the second line therapy. This is up to about a year ago. Obviously, there are potentially additional approval that's not here. At the end of the slide presentation, which I will also share with you, there is more detail about the approval for each of the disease site and what is approved for. It also have approval for tumor agnostic for pembrolizumab and dostarlimab in patients with MSI high or MMR deficient, and also TMB high for pembrolizumab. So in about a decade ago, there was a very strong interest in looking at potential synergism between radiation and immune checkpoint therapy. We know that when we irradiate the cells and the tumors, we cause a lot of immune stimulatory activity, including immunogenic cell death, expression of damage-associated molecular patterns, secretion of immune-stimulating cytokines, T-cell infiltration, increased neoantigen and antigen presentation. We have activation of dendritic cells and increased expression of these PD-L1 molecules. So we thought that together with immune checkpoint therapy, the treatment should be very synergistic with each other. And so that was also validated in multiple preclinical study when in here, an example from Dr. Weizenbaum's lab, where anti-PD-L1 was given together with radiation. And you can see that there's definitely a decrease in tumor growth to almost undetectable compared to the treatment with radiation alone or radiation with anti-PD-L1 therapy. At the same time, the question is how best to give it. And this is the data coming from a UK group and it's really one single paper that came out at the time showing that if you give the anti-PD-L1 at the beginning of the radiation course, this is a 2 grade given over 5 days to 10 grade total. And they compared to giving anti-PD-L1 before, after the end of the radiation, or afterward. They showed the data suggested that when you give it at the beginning of the radiation course, you have better tumor control with better survival in the mice. So that stimulated multiple clinical trials. And I'm going to give you an example of a trial in head and neck cancer, which I know best, where patients with stage 3-4, primarily HPV negative head and neck cancer, were randomized to either chemoradiation with placebo, which is a standard of care, versus a chemoradiation plus avelumab, which is an anti-PD-L1. And avelumab was given before, during, and for a year after chemoradiation. And the result, unfortunately, showing that the experimental arm, the avelumab arm, was actually worse in terms of progression-free survival and overall survival compared to the standard arm. And so this result was also replicated using an anti-PD-1 therapy, pembrolizumab. Over 800 patients were randomized. And you can see that the addition of pembrolizumab does improve slightly event-free survival, but there was no difference in overall survival. In energy oncology, we thought that maybe testing with the radiation alone in patients with who cannot tolerate cisplatin. So these are patients with advanced, primarily HPV negative head and neck cancer, but cannot have cisplatin. So they were randomized to either radiation plus cetuximab, which is a standard of care in this country, versus radiation and durvalumab, an anti-PD-L1 therapy, 1-to-2 randomization. And the result, unfortunately, showing that the radiation and durvalumab actually did worse compared to radiation and cetuximab. That make a lot of people go back to the lab and look at more different tumor models, especially the less immunogenic tumor model. And here's another preclinical study, look at different tumor models, but not so immunogenic. And they show actually that if you give immunotherapy and anti-PD-1 agent here, after radiation, you actually did better compared to before radiation. So and if you look at the radiation does increase inside the tumor, the CD8 T cell. But if you give it after the radiation, you have more active CD8 T cell compared to if you give before. And the T cell, the same thing here. If you give it after, you have the proportion of inactive T cell is much less compared to giving before. So has that been validated in human? And I think this is a very important study performed at University of Pittsburgh, where they take patients with stage 3-4 HPV positive or negative head and neck cancer, and they're randomized to chemoradiation, but the randomization is to give pembrolizumab, an anti-PD-1, after or before, during, and after chemoradiation. And they show that actually when you give it after, you have better local regional control and also somewhat better progression-free survival compared to if you give it before, during, and after. So have you seen that? Is it just head and neck cancer, or can you see it in other settings? And unfortunately, in other settings, we don't have a direct comparison like that, but we do glean from data from different clinical trials with similar agent, with similar patient population, but with the anti-PD-L1 therapy given different way. So if you recall, non-small cell lung cancer, the Pacific study, it randomized patients with chemoradiation to either durvalumab or placebo after the completion of chemoradiation. It was a large study, and it was very important study because it saw a substantial improvement in progression-free and overall survival in these patients, bringing durvalumab into the standard of care for non-small cell lung cancer. So the company thought that maybe because if you give it after and you do so well, maybe if you give it before and during chemoradiation, you even have better outcome based on preclinical study. So this is specific 2, exactly the same design at patient population as specific 1, but now the randomization is radiation and platinum, 1 cycle of pre and concurrent and adjuvant, and there was no difference in terms of outcome for this patient population. In the small cell lung cancer setting, it's a similar story. We have 2 trials that were kind of running in parallel. The first trial was conducted by the company AstraZeneca, where a patient with limited stage small cell lung cancer, the standard of care is chemoradiation, as shown here. And so the randomization is the patient receive either durvalumab, an anti-PD-L1, or durvalumab plus tremelimumab, which is an anti-PD-L1 and anti-CTLA-4 combination, versus placebo. And what they show is that in relation to the placebo, adjuvant durvalumab resulted in substantial improvement in progression-free and overall survival, leading to the approval of durvalumab to be used adjuvantly in this setting. Whereas in energy, we actually conducted a similar study using a related agent, atezolizumab, another anti-PD-L1 inhibitor made by Genentech, and is also approved in the very active in small cell lung cancer and recurrent metastatic setting. And the randomization was chemoradiation alone versus atezo given before, during, and after chemoradiation. 540 patients were randomized. There was no difference in either progression-free and overall survival. What about in NPC? Here's another example where it's one of those few studies where when an anti-PD, this is conducted by the same institution, 2 different studies conducted in a similar timeline using 2 different anti-PD-1 that were made by 2 different companies in China. This is a continuum trial where patients with stage 3-4 NPC, exactly the same selection criteria. In the continuum study, the randomization is standard treatment, which is induction chemotherapy followed by concurrent chemoradiation, versus sintilimab given before with the neoadjuvant chemotherapy, during chemoradiation, and after chemoradiation. There was an improvement in progression-free survival, but so far not yet improvement in overall survival, and we're waiting for result of that. At the same time, the same institution conducted a DIPPER trial, which is a different anti-PD-1, but it's still anti-PD-1, similar patient population. But now everybody get done with chemoradiation and they get randomized to adjuvant only. So observation versus more immunotherapy. And they see exactly the same improvement in progression-free survival and a similar result in overall survival. So that makes us think, what's really the most critical here in the setting? Likely adjuvant setting. So if you go back and take a look back at what's approved, I've shown you what approved in the recurrent metastatic setting. Now I'm going to show you what's been approved in the US in the non-metastatic curable setting. And if you look, just skim through this, I'm not going to have time to go for individual one. Most of the approval is actually on the adjuvant, which is after treatment, after chemoradiation. The only neoadjuvant approval is usually before surgery in patients with resectable disease. And you can see that in in lung cancer, in breast cancer, more recently in head and neck cancer with neoadjuvant after surgery, and then concurrent and adjuvant for resectable head and neck cancer. The only concurrent approval right now indication with concurrent chemoradiation is patient with cervical cancer, stage 3 and 4A disease. That's the only approval we have for concurrent chemoradiation with pembrolizumab. In another study, which is it's not approved, but is considered to be a positive study, is a sarcoma study. So a patient with selective high-grade, certain type of soft tissue sarcoma, UPS and LPS, are stratified by grade. And then a small study that were randomized to standard treatment, which is pre-op radiation followed by surgery, versus the experimental arm, which is pre-op radiation with three doses of pembrolizumab, followed by surgery, followed by adjuvant pembro for another year. And this study showed an improvement in disease-free survival, not yet difference in overall survival, and the improvement was primarily in patients with grade 3 tumors, and improvement was seen in freedom from distant metastasis, but not in local relapse. So one question that a lot of people have is when we do radiation, especially in head and neck and lung and others, we do treat a large field. We do prophylactic nodal radiation. And we know that immunotherapy may need the draining lymph node for it to work. So the question is, does that have to do, with some of the negative effect that we may see? So here's going back to to address that, people went back to mouse study and they look at, okay, let's just take out the lymph node, easiest thing to do a neck dissection. And so these mice are given the either anti-CTLA-4 or anti-PD-1. And if they give the drug in this immunogenic tumor, you can see a response here. But if they take the lymph node out with the neck dissection in red, you lose the response, as shown here. And the mice actually die faster than those that can control group. The question is whether we see the same thing with radiation. And so Dr. Sanam does the same thing, where they take these tumor, they irradiate only the primary site, or they irradiate the neck, and together with an anti-CTLA-4. And if they irradiate only the primary site, they've actually seen an improvement in tumor control with anti-CTLA-4, but if they do elective nodal radiation to the neck, they've actually lose that effect. The main issue is that they see an increase in distant metastasis in the mice that receive elective nodal radiation. And they believe that because elective nodal radiation does reduce systemic response to immunotherapy and epitope spreading. The main issue is that if they follow these mice long enough and they irradiate only the primary site, they actually have more nodal relapse. And so these mice actually ended up having to do a neck dissection, or a sentinel neck dissection, they call it in these mice. And if they do that, they've actually have improved survival. So you're trading off a little bit of local control by not irradiating local regional control, by not irradiating some of the nodes, but you enhance distant control. So this is a lot of data that we need to figure out how to validate in patients. So the yin and yang of radiation, I talked to you about how radiation was thought to have a lot of stimulatory effect, but it also caused a lot of immune suppression, such as the secretion of TGF-beta, cause hypoxia and stroma reactivity. The radiation does decrease MHC expression and antigen presentation, autophagy induction, lymphopenia, lymph node suppression, as I mentioned to you, and also enhance myeloid cell, which are very immune suppressive. And so with that, we're going to have to figure out how to take a step back, figure out how to do radiation in terms of dose, what is the best dose and fractionation besides sequencing. Can we spare the lymph nodes? How can we use a biomarker to predict this? And how can we use approaches that are more immunogenic and less immunosuppressive, especially on induction of myeloid cell? So I just want to share with you today that the clinical data do not support the use of ICI with chemoradiation as given in locally advanced setting, except for cervical cancer, sarcoma, and maybe NPC. So the data primarily support adjuvant treatment. Focus should be used on how to optimize radiation field fractionation to counteract the potential of immune suppressive pathway. And at the same time, we need to make sure to maximize the therapeutic index and not overtreat patients with multiple modality. The question also is how many of these patients actually need ICI for up to a year in the curable setting. So with that, I'd like to conclude and thank all the patients enrolled in these clinical trial, all energy investigator, staff member, the grants that support energy research as well as my research, and obviously the leadership within energy oncology. Thank you.
How do I activate this one? Now, I'm going to introduce the second speaker, but I'm going to give you the caveat that the second speaker is actually not going to be able to speak, but he is part of this. So the two slides that I'm showing you are people that are not part of this U.S. Pakistani Oncology Working Group who have agreed to speak to us, but to be engaged with us. So the second person we asked is Badrusan Vikram, Dr. Vikram. He had gotten his degree from the University of Delhi, did his training at Memorial Sloan Kettering, was on faculty there for some time, and then he ended up becoming the chair at Montefiore and Albert Einstein. From there, he went in 2002 to 2006 to the International Atomic Energy Agency of the UN. While he was there, he helped create the program of action for cancer therapy, and so he shared in the Nobel Prize for that project. Since then, in 2006, he came back to the U.S. and was the chief of clinical radiation oncology branch at the NCI, and he was overseeing a number of different programs, including CTEP, which is the Cancer Therapeutic Evaluation Program, and the NCTN, and then also the Experimental Therapeutics Clinical Trials Network. And then he's had a lot of work with the Global Health as part of the NCI. So I'm introducing him regardless because he is going to be engaged. So this was the email that we got just January 15th. Has nothing to do with the symposium. He was ready to go. He had stepped in 2 years ago as well to give a talk for Norm Coleman. But he is very much interested in helping with clinical trials, and he does leave his email here. Here's the key thing I wanted to say, and this is going to be about clinical trials, but really anything, if you have any questions or anything, it's please publicize my email to all the attendees. And they should feel free to address him directly with a 1 to 2 page idea and any questions. So our job is to open up a pipeline to anyone here. And even though he cannot speak today, he is a willing partner. Okay. I'm going to switch to the third person who's going to be live online coming from the New York area. I don't know if you can bring up the Zoom link for him. Go ahead. So that'll be good. I'll introduce him briefly. So this is going to be Dr. Mansoor Ahmad. He has spoken here before. Dr. Ahmad is, had gone to school in Madras, had done radiobiology work in Japan, was at Thomas Jefferson University, then the University of Kentucky, then Geisinger. He is currently the Director of Radiation Biology and Molecular Therapeutics at Albert Einstein. He was, before this, the Program Director in Radiotherapy Development Branch and Molecular Radiation Therapeutics Working Group at the NCI. So another person from the NCI who also spends a lot of time with global health. He works with the Center of Global Health for the NCI, has helped with opening trials in India, China, and through the IAEA. Also interested in helping. Recording in progress. Recording in progress. So Dr. Mansoor is here with us live, even though it's the middle of the night.
I see him here. माइक को म्यूट ओवर प्रीमियर से माइक कहाँ से चलेगा इसका माइक म्यूट करो प्रीम माइक म्यूट करो
Can you hear me?
Yes.
You can hear me? Okay, so basically, my title of my talk is a bit different. So I'm going to go beyond the conventional fractionation, what's being used as a standard of care. More importantly, trying to put a spin in terms of how radiation can exploit the cancer hallmarks. Particularly, we had a workshop in NCI on the shades of gray, looking at various doses as immune modulatory drugs or just the drugs because it has unique biology by itself. So more importantly, I think I'm going to focus more as the low dose part to see how one can exploit potentiating the effects of chemo. At the same time, it can be a good immune modulator. So I don't have any disclosures. So just to give you a thought, one size fits all, that's what we have been using as a standard of care with the traditional uniform radiation dosing to the tumor. But unfortunately, we have not looked beyond the standard fractionation. So one of the key things, what I'm trying to introduce a different spin here, like when you have this 14 hallmarks, can we do a precision dosing to these cancer hallmarks by various doses of radiation, which is basically what we are talking about, the ultra low dose to low dose and the clinically relevant dose, which is conventional RT, and then get into subablative phase and ablative phase and complete ablation. So bottom line is that when you look at this dose range, basically each dose range has a different biology and a different therapeutic actions. So that's one of the reasons, because when you really look at that, these dose range activates distinct molecular pathways and cellular responses. More importantly, the right dose depends on the therapeutic objective what you have. So these are the 14 hallmarks, which I don't want to go through in the sense that because of the time. So the standard hallmarks that were reported by Hanahan was basically the 10 hallmarks, starting from sustaining proliferative signaling, evading growth suppressors, resisting the cell death, replicative immortality, and then inducing angiogenesis, activating the invasion and metastasis, deregulating metabolism, and avoiding immune destruction. So the enabling hallmarks that came in between, when more science developed in terms of the genomic instability and mutation, and at the same time tumor promoting inflammation. Then you have the current emerging science that has gone into cancer biology that led to more understanding in terms of the phenotypic plasticity, epigenetic reprogramming, polymorphic microbes, and senescence. So the challenge here is that can different doses selectively target these hallmarks? I'm still working on to understand how these hallmarks can be targeted. I'm just looking at the literature to see if there are any reports with specific doses of radiation. But nobody has done a systematic study to see how one can target this hallmark. Yeah, definitely there's a lot of studies coming out now, particularly in the eighth hallmark, avoiding immune destruction, where low dose and high dose has been used there, So just to give you a sort of a dose response relationship, particularly in different dose categories, from 0.1 to 2 gray, basically it has a significant primary effect at the T helper, like a Th1 type of a response with immune priming. And there is clinical evidence that low dose RT increases infiltrating T cells. It also causes MT to M1 shift. Now, with the clinically relevant dose, yeah, naturally there is a vascular normalization it can lead to, and then it can also lead to senescence, But again, it has certain clinical evidence also. But when it goes to more into the sublative phase, 8 grade 3 times, I mean, that's what most of the combination with immunotherapy has been done. That's the optimal immune modulation dose that has been worked, particularly from Sandra Di Maria and Sylvia Formanti's group at Cornell, And in fact, this was used in a bigger study, which was NCI-sponsored study, which I will talk to you about as I go through this. And again, the sweet spot can be important also in terms of getting into ablative phase, Then you have other things to consider. And again, there are many hallmarks that can be targeted there, So with that being said, I'm just giving you differences between extremely low dose to extremely ablative dose. So what happens in terms of the DNA damage, cell fate, and vascular effects and immune priming, and what is optimal for, So basically, with that sort of a summary in the beginning, I wanted to get into how one can exploit the low-dose fractionated radiation as a dual action agent for chemopotentiating effects as well as immune modulator. So one of the things it was when I was in Kentucky with Dr. Mohiuddin, basically we did some studies looking at comparing the clinically relevant dose of 2 gray to sensitize the effects of paclitaxel. This is like 20 years ago, in a P53 mutant background, basically. Now, what we saw was that with the 2 gray radiation dose with the P53 mutant background, we were not able to sensitize. But when I made the doses 0.5 gray BID or 1 gray in 2 fractions, I was able to sensitize significantly the effects of paclitaxel. So that sort of opened up. And at the same time, Mike Joyner from Gray Labs, he published an interesting phenomena where when you look at the cell survival curve, particularly in the low dose region, where he mapped for nearly 40 tumor lines, basically, where there was a clear dip at low doses, like a 0.1 gray to 0.2 gray or 0.3 gray. And then basically the dip goes up, leading to more induced radiation resistance. So that dip, he called that as hyperradiation sensitivity phenomena. Now, one of the key things is that in the tumor cells, particularly the HRS phenomena, in terms of the mechanism, what he saw as well as what we saw in the tumor background was that these doses do not activate ATM. There is no DNA repair. And we didn't see any pro-survival signal. There was a direct BAX activation leading to apoptotic pathway induction, as opposed to completely a different scenario when you go doses above 1 gray or clinically relevant dose of 2 gray, where we see all these DNA damage repair programs are activated. You have pro-survival mechanisms are also upregulated, and it also shows to involved in induced radiation resistance. So, And again, remember, normal cells do activate ATM at 0.5 gray, but more importantly, tumor cells require more than 1 gray to activate there. So with that being said, because the switch, what you see between normal and tumor cells, so one can exploit this therapeutic window in the clinic. That's what the whole idea here is. So basically, since it is dose-dependent activation of ATM, that means with less than 0.3 gray, there is no arrest. With mitosis with unrepaired damage leading to cell death, that's what the HRS phenomena is. Whereas much higher doses can lead to early G2M arrest and repair before they mitose, and then there's a cell survival induced radiation resistance. So bottom line is that the low dose can exploit the genomic instability while preventing the development of resistant mechanism triggered by conventional doses. So in my lab, we tested various chemotherapeutic agents from taxanes to gemcitabine, cisplatin, temozolomide, in various cell lines. And we saw significant, chemopotentiating effects of particularly, we are talking about 0.5 gray BID. This is what we saw when you compare that with the 2 gray 1 fraction, and that was given in 8-hour interval, basically, So, and again, we also mapped some pathways, and particularly we did a pretty hallmark study with a head and neck xenograft study where we found that LDFRT, that is low dose fractionated radiation, what we did was Monday, Tuesday, we did BID 0.5 gray combined with docetaxel, and then we repeated this for 6 weeks. It's the same thing, we compared that with 1 gray again repeated for 6 weeks with docetaxel, and at the same time we also did 2 gray single fraction. And interestingly, this was the most significant of all the LDFRT plus docetaxel, 12 out of 13 mice. Basically, we monitored them for nearly 9 weeks, and there was a 92% complete tumor control. This is basically in a preclinical study that was published already. So we mapped a lot of mechanisms in terms of the low-dose fractionated radiation in different background, and we clearly saw that there's induction of apoptotic mechanism. At the same time, there is no induction of pro-survival mechanism with the low-dose fractionated radiation. And we also saw that MDR1 is not really regulated at the LDFRT dose. Interestingly, that is much more regulated with the conventional IR dose. So we mapped those signaling pathways and then reported this in various publications. So with that information, so there was a clinical trial designed by Susan Arnold at University of Kentucky. Basically, there were 2 trials. The first trial, she used 80 centigrade in combination with Taxol 225 milligram per meter square with carbo. So basically that was a pretty high dose, and they did 2 cycles, and then they looked at the response assessment as an induction regimen followed by definitive surgery or radiation. The trial 2, they reduced the LDFRT dose to 50 centigrade, and then they also reduced the Taxol. The trial 2 was better than the trial 1. The response rate was 95.8% overall, with 62.5 complete response. This is the response assessment that is done before the definitive surgery or radiation. That's what I'm trying to say here. So the median overall survival in these cases were 107 months. And again, this was superior to intensive 3-drug regimen with lower toxicity there. Now, I collaborated with a group in Chengdu at Sichuan Cancer Center where Mei Feng, she basically irradiated the positive lymph nodes with 50 centigrade BID 2 days with each induction cycle. I think she repeated this for 3 weeks actually. And you can clearly see that the LDFRT group, there was a significant lymph node volume reduction to 91.52%. There's overall response rate of 100%. They did 41 cases, 41 in LDFRT group versus the arm in control group also 41 there. Compared to 100, it was like 85.37 there. Now, the 2-year progression-free survival was 87.59 as opposed to 70, what you see, the historical 2-year PFS, particularly for high-risk N2 and N3 patients, so. And again, the distant metastasis-free survival was also much higher in this group. So the bottom line was that it was safe. Acute toxicity was comparable between groups. There was no dose-limiting toxicity from LDFRT, and at the same time, the grade 3-4 events similar to leukopenia and neutropenia. And again, it was an excellent treatment compliance in both the arms there. And then I collaborated with Kristen Redmond at Johns Hopkins, and we did some preclinical study with temozolomide and 0.5 gray LDFRT in combination. And she did this trial, basically, she did 0.5 gray twice daily, 6 hours apart, with concurrent TMZ on days 1 to 5 with 6 cycles, basically. And then they gave adjuvant TMZ for 6 additional cycles. Total dose was like 30 gray. Now, more importantly, while the primary survival endpoint was not met in this study, more importantly, what we saw here was that there was a pretty high pseudo-progression rate, nearly 77% at the low-dose radiation doses, basically with a median of 10 gray. I mean, basically, pseudo-progression can be more of a immune infiltrate, basically that sort of gives you a compelling evidence for the principle that low-dose hyper-radiation sensitivity as well as the potential immunomodulation. So the treatment was safe, and basically it did improve some survival, but it warrants more further investigation, basically. This just came out in the Red Journal like 2 months ago. So this has been applied across various tumor types, even in ovarian cancer to cervical cancer, pancreas. Bill Regine did some studies, and even the lung cancer. So the bottom line is that low dose is a powerful agent to transform the tumor microenvironment. More importantly, there are immune activation pathways that leads to dendritic cell activation, T cell mobilization. There's a macrophage repolarization, and there's also enhanced NK natural killer cell recognition, and it also sort of releases damp also without overwhelming damage. So when you compare these two, basically with the high dose and low dose, basically you have more positive immune modulation advantage there. So. With that being said, when I was at NCI, I was involved in a project team. That was the first study that was done in combination with checkpoints. More importantly, we tried to introduce, to compare with the high dose 8 grade 3 times in one arm. In the other arm was the LDFRT. And the third arm was just a dual checkpoint. One was done in metastatic non-small cell carcinoma, and the other one was done in metastatic colorectal carcinoma. So basically, in metastatic non-cell lung carcinoma, that failed to respond to prior checkpoints, and at the same time, in the metastatic CRC, there was progression more than 1 plus chemotherapeutic regimen, but MSI tumors were excluded there. So, but here I don't want to get into the clinical part, but more importantly, comparing 8 grade 3 times with the low dose. So we did this biomarker study with the immune monitoring core, and you can clearly see that, there was significant, macrophage repolarization that occurs, that you didn't see that in the high dose radiation. And at the same time, there was a significant T cell infiltration, and there was very increased micronuclei or nuclear rupture, what you saw, that was very pronouncedly increased. And again, there was an interferon gamma response. So bottom line is that I think when you see micronuclei formation, and that is critical for gas-sting pathway. So LDF40 can uniquely induce this pronounced micronuclei in a clinical situation that can trigger more of an innate immune sensing. And again, macrophage repolarization is also an important thing, and that is critical for anti-tumor immunity. So overall, if you see that LDF40 generates a distinct immunological signature that favors tumor microenvironment remodeling, basically without lymphocyte depletion. So why is it powerful in terms of using LDF40? It can chemopotentiate, and plus it can also cause immune modulation. This is a significant synergy for local control, distant control. It can be a good insight to vaccination. And it's easy to design this optimal dosing strategy. Basically, what I say is that based on the preclinical data, what I have done, it's important to look at what cell type you're looking at. Sometimes the HRS regions in these cell types can range anywhere from 30 to 80 centigrade, depending on, then you can design your dose fractions in that range. And then basically you need to give 2 dose fractions per day with 4 to 6 hours interval, mainly because of the cell cycle, exploiting the cell cycle effects, And that needs to be done in 2 days in combination with chemo, and then you repeat this several cycles in order to get a better response. And again, this can be done as an induction regimen, so that's the whole idea here. So in conclusion, the key takeaway from this is that it's a dual mechanism. Basically, both chemo potentiation and immune modulation work in synergy. And the genomic vulnerability, basically, it exploits the DNA damage repair mechanisms, the thresholds, hence prevents the resistance. And it has been tested in several solid tumor models, with the clinical validation. So currently we are opening up trials for peritoneal carcinosis in Einstein. We are starting to work on that. Thank you.
Sorry. While Dr. Ahmed is here, does anybody have a quick question for him about some of the biology?
Queen Lay is also there. Dr. Lay is here.
Oh, she is. Dr. Lay?
Yeah, you should.
Yes, I'm on.
Oh, that's wonderful. I didn't realize you
Thank
were
you.
able to join us. Does anybody have a question for either of them at this moment? We do have a last speaker, but while they're here online. Dr. Lay, did you have any other comment you wanted to make after your talk?
No, I think I was trying to make the point that at the current state with the dose that we give, with the field that we give, we've got to be very careful about trying to say that the radiation is an immunomodulator in terms of immune stimulant, and because the clinical trial has not panned out when anti-PD-L1 or CTLA4 is given together with radiation. So I think we're all trying to go. There's a lot of inhibitory effect from the radiation, and so we're trying to figure out how we can modulate that inhibitory side, the myeloid side of radiation as well.
We do have a question. Go ahead.
Yeah, so thank you very much for an excellent talk, Dr. Mansoor and Dr. Lay. So Dr. Mansoor, I had an opportunity to work with Dr. Mohyuddin for 5 years in Riyadh, and we conducted a little bit of a small little head and neck trial for the dose you just were suggesting, half a grade twice a day for 2 days for all platinum docetaxel kind of advanced head and neck cancers. My question to you is that you are conducting, of course, mostly biological things and now progressing into the clinical domain using this type of immunomodulatory radiotherapy. My question really is in terms of combination of this, do you perceive that it is going to do better with currently as it is being done with systemic myelosuppressive chemotherapy, or do you think it'll be better done with checkpoint inhibitors?
Well, I don't think anybody has tried in combination with dual checkpoints and CRT together. I mean, CRT in the sense chemotherapy with the LDFRT. I think Shezwan Cancer Center is planning to do more targeting the lymph node with 0.5 gray. Again, they have done this with induction chemo. So it looks good to, I mean, I just showed you the data of the trial, which they are, trying to look for. This is in NPC actually. So I think, I don't know what will be the consequences in terms of combining dual checkpoint in that setting.
My question background is basically both pertaining to you and Dr. Lay as well in terms of timing of the using checkpoint inhibitors with radiotherapy. So my question really is in terms of what the cancers we see in Pakistan, what more commonly at a very advanced stage, which is cervix cancer. So as Dr. Lay mentioned, that only approved combination right now is the Keynote A18 combination for advanced cervix cancer. We see usually patients presenting here with massive tumors in the pelvis, and Keynote starts with radiotherapy and immunotherapy together. So my question really to you, Dr. Mansoor and Dr. Lee, is that do you feel that in those patients there is an opportunity to throw in this low dose thing with Pembro or whatever as a neoadjuvant, as they were trying to do in Interlace using neoadjuvant chemotherapy to downsize the tumor? Would you suggest that if you are going to use, say, for example, Interlace style chemotherapy for Taxol Carbo, only 6 weeks treatment, would you think that there will be some benefit of combining this low dose radiation with a quick effect seen in 6 weeks' time, because then patient is going to proceed to have a radical dose of chemoradiation?
Quinn, I think I can, I mean, the thing is that all these low-dose studies were done as an induction trial, followed by definitive treatment. So I'm sure, what you say, that can be done. But I would like to, I know that Quinn was there in the talk. So what are your thoughts, Quinn?
Actually, Energy is mounting a trial. I think it's, I have to check on the GY number, but it's immune prime because cervical cancer, as you mentioned, the very advanced and the current approval is stage 3 and 4, FIGO stage. And so they actually, there's some data with at least from lung cancer, you do chemo IO first, and then you go to the procedure. So they're doing an immune priming approach where they will randomize patient to chemo Pembro, followed by chemoradiation and Pembro versus the definitive setting like the Keynote aspect. So the trial just got activated, and I think they're looking for collaboration, international collaboration on that as well.
Great. Yep. So what's the dose there for the immune priming?
so there's no radiation immune priming.
There's no. Oh, okay.
Chemo IO, so chemo pembro, followed by chemo radiation and pembro, and more adjuvant pembro versus the standard, which is chemo radiation pembro and adjuvant pembro.
That'll be wonderful to, put in the low dose. I mean, Jonathan Schoenfield published that in the Lancet Oncology, as well as ARTA, once at these two trials from NCI, so with low dose. They compared with the high dose, but there was no no chemotherapy, but that was more of a dual checkpoint there.
We do have one more talk. Are you both able to stay on for another 10 minutes and then take a couple more questions? Or is it?
Yeah.
Is that
that's fine.
true for you also, Dr. Lee?
Okay.
I know it's very earlier.
Yeah, it's past midnight here.
Are you okay with that? If we just take a couple questions? I apologize then.
I've got a question for
Okay, we got a couple questions, including the next speaker. All right.
Are you going to ask first for him? Hi, Dr. Lay, this is Mohammed. I think you know me from Emory. I've got a question. Actually, my talk was going to talk a little bit about immunomodulation, and more specifically, the RAS-scopal and the abscopal effects happening at the same time. What are your thoughts about that, and what is NRG doing in terms of trials? And that's going to answer the question that Mazur is talking about, which is using low doses to remove inflammation and opening up the tumor environments for priming and allowing those cells to get into metastatic sites. And at the same time, using ablative radiotherapy to get antigens to be shed, have lymph nodes taken up, combining with checkpoint inhibitors. So what are your thoughts about those trials in energy with using sort of mild hypoablation or those type of approaches combined with low dose FRT that Mazur talked about?
Yeah, I think if you're talking about the RAS-scopal effect, is that the same thing that James Welsh from MD Anderson was talking about? I think we tried to take that to do a randomized study at NCI. It got it got rejected. I think but I'm a little bit. The main question is why there's, as you know, there is an alliance study with SBRT and randomize that with IO versus I think it was just like the same one that Joe what's his name from MD Anderson published, was a phase 2 that was positive. And my understanding from the Alliance study is that trial is not going to be positive. So it also make me take a step back to think about, the ablative radiation that we think about may or may not work in patients as we have expected in the setting. So we need to understand, take a step back and understand how to give the drug together with this. I think there's a lot of trial going past the RAS-scopal to the abscopal effect. I think there's a lot of trial trying to do that, to do the abscopal effect, and there's a multiple negative small trial in the current metastatic setting where they just, they treat one lesion and they try to get a systemic response in patient with disseminated disease, and that hasn't happened. And I think if you talk to Ralph Weisenbaum, and I'm on his cam, is that I think you need to treat if you have a patient with a large tumor burden, treating one lesion doesn't help. You need to treat most of these lesions. So I think until we prove it, it's going to be hard to translate findings from mice to human.
I think we have one more question.
Yeah, no, thank you very much. I'm Dr. Ali. I'm from Britain, and thanks for a wonderful talk. We look forward to Khurram's talk next to enlighten us more on this. So I keep it very simple. There are two things. One is what have you seen so far in terms of toxicity?
Is there any increased signal in terms of toxicity when we're combining both modality together in different dose levels? Secondly, immunomodulation. So would radio-resistant tumors become more radio-sensitive, like some of the kidney cancers, melanomas I treat skin as well. So what do you think about, what is your take on it, that by combining two modalities, would that radio-resistant tumors would be more a candidate, or would there be a window of opportunity for us to utilize more radiotherapy for those tumors? Thank you.
So I'm going to address the second question first and then go back to the first question. I think, it's really hard to sort that out in terms of radio-resistant tumor, because there's some, depends on the mechanism of radio-resistant. We've, as far as I can tell, there's a few mechanisms for radio-resistance, such as, the mutation of the KEAP1 NRF2 pathway. And if you have that mutation, you've also become resistant to chemotherapy. And there's recent studies showing that it changes the metabolism of the tumor and also make them more resistant to immunotherapy. So the question is it depends on what the mechanism of radio-resistant is. We know that, at least from the mouse study, that if you have no immune system in the mice, back in the data in the 70s and 80s, you need more dose. So the immune modulation does help enhance response of the tumor to radiation in the mice, but it's unclear. It's my roundabout way to say that it's really hard to lump everything into one category, because a different way the tumor resists to radiation, and I think it depends on what mechanism it is, whether you think the immune modulation would help. So that's my roundabout answer. Mansoor, do you have anything to add to that?
Well, you're right. Basically, when you radiation is a good immune modulator, but at the same time, it can also create an immune suppressive environment. So the question is, when we are talking about radiation sensitivity, which is, the target is DNA, DNA damage repair and genomic instability, that also has an indirect influence in terms of increasing TCR diversity that can also have an influence in radiation response, particularly in the immunogenic cell death. So it all depends on the dose, what you play with, and it all depends on the genomic status of the tumor too, So there's a lot to look into it there, So there's a very clever management you have to do in a holistic manner to understand various components. You need to really match different things with tumor microenvironment components with the radiation dose at the same time, what kind of checkpoints and sequencing you use. So then you can put that precision approach in each patient, So.
No, that's very helpful.
And the other thing,
so
if you look at
low-dose radiotherapy should be carefully chosen then in terms of radio-resistant mechanisms, as you mentioned.
We're running up against a deadline, which is, in this case, Juma, and I have one more talk. So,
okay, that's right.
If you don't mind, if we could table that one question for the next.
Quinn was saying something. Quinn, go ahead and finish your comments.
Yeah, I think the main thing is if you look at the data in terms of when you combine radiation or chemoradiation with immunotherapy, the biggest bang for the buck is with metastatic control, less with local control. So what you can interpret however you see it, but I'm not sure if it helps with the radiation aspect of things.
The fact that we're running out of time and that this session is going longer is a testament to your engagement. So I do appreciate Quinn, Mansoor, you both getting very much involved. Everyone's very excited to hear, and keep asking you more questions. So thank you for being engaged despite the distance and the time. The next person and I'm hoping you can join us for tomorrow, because there'll be even more questions tomorrow. I don't know. All right, clinical trial-wise, but thank you so much. It's much appreciated. So the next person I'm going to introduce is here in person. This is Mohammad Khurram Khan. He is currently a professor at Emory University. He had been in Tennessee, did a nuclear engineering degree and PhD, then was at Cleveland Clinic for residency. Now, like I said, is at Emory. He's an expert in lymphoma, multiple myeloma, skin. He's also the vice chair for education, and just last year won the 2024 Innovation for Impact Award, which is for people who are thinking outside the box and are changing paradigms. It's a very rare award that's given by Emory, only to 2 people a year. That was Khurram. First talk was about ICI and regular radiation. Second talk is about low-dose radiation for cancer. Third talk is about low-dose radiation now, but for benign conditions.
So I'm going to talk about benign indications and low-dose radiotherapy, but I'm also going to tie in what the 2 speakers talked about. So a lot of my work was actually for the last decade understanding radiation and how radiation impacts the immune system, and actually combining with checkpoint inhibitors. I started that research back in 2010, 2011, when it was even in the infancies of thinking about radiation's impact on the immune system. So I've got over 10 or 14 years of history of highlighting a lot of things that Quinn talked about and some of the papers that was mentioned. But I won't talk about that. I'm going to talk about some of the new things that are ongoing, which is about, do we have, okay, there it is. Go to the slideshow. So I'm going to talk about the low-dose radiotherapy, and I think low-dose radiotherapy is what we're starting to learn about now, and what we're going to see for the next 5 or 10 years. Before I start my talk, I just want to poll the audience. How many of you actually treated with low-dose when COVID was around? Anyone treated COVID-19 patients for pneumonia infections? No one. I didn't expect that. How about arthritis? Has anyone treated arthritis here at all? I didn't expect that either. Okay, maybe a few people have. What about congestive heart failure? Has anyone treated congestive heart failure with low-dose radiation at all? And what about Alzheimer's? Good. I didn't expect that. 5 years from now, I'll come back at this podium. I'll ask the same question. I'll see how many hands goes up. So let me talk about this right now. How's it switch the slides? Can you go back to the first? Yeah, it's not working. Okay, let's go to the next. All right. So I'm going to talk about low-dose radiotherapy and how in the U.S. we started sort of believing in low-dose radiation, at least during the COVID-19. A lot of papers came out. I ran the world's first trial in the USA, and also Iran, Spain, India, many other data came out. And even the preclinical data came out to support low-dose radiation, at least for COVID-19. I'll explain why COVID-19. A lot of the biology mechanisms that I learned in COVID-19, and then started thinking about what was happening in the European and in other parts of the world. And a lot of folks in the U.S. also started looking outside of the United States and looked at what the Europeans were doing was actually using low-dose radiation for osteoarthritis. And now you'll see a lot of people in the U.S. are starting to use low doses for osteoarthritis. And a lot of the mechanism and the biology we're talking about and how low doses impact the immune system are actually relevant and common in what we saw in COVID-19 and also what we're seeing in arthritis patients. And more importantly, people are starting to use that concept of biology to say, hey, can we move forward to looking at Alzheimer's patients and as well as even congestive heart failure? And I'll highlight some of the early data. Now, I don't think we have a lot of human data or human trials on congestive heart failure or Alzheimer's, but I think 5 years from now you will see this, okay? So be ready. And then I'll talk a little bit about what Quinn had talked about and what Mazur had talked about the RAS scopal and low scopal. And I don't think that low-dose radiotherapy that I'm going to talk about is only meant for benign indications. The biology and the mechanism that we learned about is going to be very relevant to cancer as well. It's not in isolation. I'll explain that. All right, so this was the first patient that I saw in April of 2020, March 2020. This was a 90-plus-year-old woman who came to me. I was at Emory, and this was a patient who was admitted with COVID-19 for 11 days. Her classical coma scale went from 14 down to 10 during the hospital course. She had a Charleston comorbidity index of a 7. She had worsening oxygen needs, and her x-ray, as you can see, showed bilateral x-ray that showed infiltrates bilaterally, 4-liter oxygen she was on daily, and that oxygen needs were going up. She was standing around 92% while being on oxygen, and she started to become unresponsive. And the internal medicine doctors who were taking care of her told her that she was having hypercarbic respiratory failure with agonic breathing. Her PCO2 was 57, and she was considered being COVID septic shock. And she was, then the family was being told her that, you know, she's going to be hospice eligible. They were talking about DNI for her was being signed. And she was set in ICU for observation with poor expected outcome. If you step back in April 2020, what therapies did we have? Zero, none. And my clinic was shut down. My patients were coming. We were talking about rationing oxygen masks. And it was a sad day for all of us. We didn't know how we were going to dig ourselves out of COVID-19. But that's when inspiration rises. Physicians champion and they fight for their patients. I, as a radiation oncologist, realized that low-dose radiation cuts down inflammation. What I did was I self-taught myself what was COVID-19 doing in the lungs. This is what I presented at Emory and around the world. What COVID-19 was doing was getting into the lungs, into the ACE2 cells, and we're getting trapped. And what it was doing was getting activation of a lot of these chemokines were being upregulated. So these chemokines like IL-6 was going up, IL-10 was going down, macrophages were being trapped. A lot of these cells were getting, so what they call the hypercytokine storm was being set in. And what happened was, if you look at all these areas on the black lines, there were actually individual mouse models that I looked at that show a lot of these cytokines that are going up are actually low-dose radiation can actually shut a lot of those down all at once. And if you look at all the drugs out there, this is what the drug companies were pushing on patients: corticosteroids, Ancanara, tocilizumab, TNF blockers, chloroquine. The chloroquine data, phase 3, had just came out negative at that point. And we, you know, in the U.S., we were talking about drinking Clorox. Yeah, with some crazy things like this, you know. And my thought was, hey, you know, low-dose radiation can do all of these things. And there was a lot of mouse models, not in ARDS mouse models, not in you know, COVID models, but in other mouse models, low-dose radiation was shown to cause anti-inflammatory effects. So we decided, why don't we offer low-dose radiation? So we ran IRB trials, and we got our first phase 1 trial published, actually approved by IRB, so 5 patients, then 5 more, then another 20, then another 40, up to 54 patients. So we went from phase 1, phase 2, phase 3. The nice thing about it is my first patient I treated, the second patient I treated, I went straight to NCI, went to my deans. Everyone knew what the results were. And so NCI, Norman Coleman, you know, all the folks you hear were actually on co-authors on these papers that we published, like in terms of statements from the NIH. And that basically said we should continue moving trials forward. But what happened to this patient? So this first patient was actually the first patient that we treated on our trial. So her, within 12 hours, this is what happens. She wakes up in the morning at 4 a.m. So one of my colleagues rounds on her, calls me up in the morning. He said, Dr. Khan, look at her. Glasgow Coma scale is 14. And she tells my colleague, Dr. Hess, my favorite baseball team is the Braves. This is someone who had a Glasgow Coma scale of 10 the night before. Within 14 hours, she's like, look, she's having a talk. She's having a Zoom meeting with her daughter. How powerful is that? More powerful than treating a cancer patient, if you ask me, actually. You know, so she said, I'd like to get some ice with my water. My lips are chapped. Of course, my bottom hurts, you know. And so these are the notes documented by the PCP that saw her the next day. And even a few days later, they said they've proven in x-ray findings. Clinically seems better. And interestingly, we treated 2 patients that night. And not her. Same story with the second patient, except it was 24 hours later, not 12 hours later. And then we treated more and more patients, and we saw these stories over and over and over again. And I was convinced this was a very potent therapy. So what ends up happening? We publish our data in the red journal, then the green journal, and the cancer, and multiple other journals. Then we had a combined statement with Mazur and with Norman Coleman and many, many other leaders. We started writing that we should continue these trials because the early data is showing success. So this is our time to recovery in COVID-19. We had patients coming off oxygen within 3 days. That's pretty powerful. Versus standard of care therapies, whatever you gave them, 12 days. It was so significant in a small number trial, it was very positive. And so we got that data published. Of course, back then, before we had COVID-19 vaccines come out, and before steroids became, steroids, just to give you an idea, do you know how many patients were in that steroid trial from England? 6,000 patients to see a 3% absolute benefit. We're seeing such a huge benefit in a small number of patients. That tells you how powerful anti-inflammatory effects of low-dose radiation is compared to steroids. At least that's what we felt. But anyways, we were all over the news. It was kind of an exciting time. But we knew this was not going to last. But we did publish our 40-patient data. And in that data, we actually compared low-dose radiation with whatever the standard of care was. So we had 20 patients that were getting remdesivir, steroids, plus LDRT, versus remdesivir, steroids alone. And what we showed that we prevented patients from getting intubated. Once again, this is more powerful than cancer treatments. A lot of cancer treatment we treat are just for local control, early prostate cancer patients, some of the early rectal cancer, just rectal, like local control. We do destroy their quality of life. Here, these patients' quality of life is getting a lot better. You're preventing them from getting intubated. So here we had a almost statistically significant difference between 86% prevention of getting into intubation versus 68%. Our cytokines and many, many other biomarkers. I'm not going to go through all this. This is all for the history books. And then one of the criticisms we had was there wasn't enough mouse models. There wasn't any. So in Paris, so one of the guys, Dr. Dosch, Eric Dosch, from Gustave Roussy, sent me the information. He said, Dr. Khan, I know you're getting a lot of criticism because you're doing these trials. There wasn't a lot of mouse models and mouse data, but you moved forward because man needed to move forward. We needed to move forward with therapies. And my results were already out. The data was already being published, and we were already seeing positive results in clinical trials. But he sent this paper to me before it got published and said, look, he created this mouse model with 3 different ways of causing ARDS in mice. So he did this C57BL6 mouse model that I use as well. He induced pneumonia in these lungs by using a lipopolysaccharide in the lungs, in the aspiration of the mouse. He used H1N1 flu and also polyic. All these 3 different ways can cause ARDS in the lungs. And he gave very low doses, the same thing that Mansoor was talking about, half a gray, anti-inflammatory effects. He gave half a gray and 1 gray. And he showed exactly what we hypothesized, that low-dose radiation increased IL-10, which is anti-inflammatory cytokine. It reduced IL-6, which is inflammatory cytokine. And it decreased interferon gamma, which is also inflammatory. And also showed this M1, M2 macrophage repolarization in that area. Same thing that Mansoor was talking about. So that's in the cancer world, but you also see it in these sort of concepts where inflammation is playing a big role in pathophysiology, and low-dose radiation can shut that down. And then so this mouse model came out. A lot of the pre-clinicians that were criticizing me backed off when this paper came out because the mouse data validated what we already saw in humans. This is where humans data went first before mouse. We needed to. Anyway, so many other trials came out around the world. Just to give you an example, Emory, Iran, Madrid, Barcelona, Spain, Trichy, India, New Delhi, Switzerland, and then Gustave Roussy. So many trials around the world came out in support of low-dose radiation. There was only one trial that was negative, and I actually had beef with the Red Journal about this article, and I criticized this because they should have never done a randomized trial of 22 patients. You can't have a phase 3 22 patients. I don't even know why Red Journal accepted it. Today I still criticize them, everyone. That should have never happened. But anyway, they did a phase 3 randomized trial of intubated patients, very advanced patients, and they found it was negative. Of course it's going to be negative. 11 patients. Come on, 11 gets radiation, 11 gets sham, and you report a negative trial. I don't think the Red Journal should have accepted it. But there's bias in the Red Journal. In the beginning, when I had a positive results, the Red Journal didn't want to accept it. The Cancer did. The Green Journal did. Then eventually, my 3rd paper, Red Journal said, yes, we'll accept it, Dr. Khan. So anyways, I'm sorry. I have to say it. It's true. All right. So a phase 3 randomized trial did come out. So a lot of people say, was there a phase 3 randomized trial? Yes, there was a phase 3 positive randomized trial done in India. And this was published in the Green Journal that showed low-dose radiation did help COVID-19 patients. And they showed that improved oxygenation and CT severity scores, and the time to clinical recovery, and then hospital discharge was better on these patients. And it's actually important for a place like India. They don't have oxygen tanks. They don't have remdesivir. They don't have all these drugs. So it's very, very important for lower middle income countries or countries with limited resources. So this is why we were doing these trials. Not so much what we need in the US, but what the world's going to need. All right. So what happened in the U.S.? So 2019, 2020, 2021, we get these papers out. 2022, we're done. You know, we got vaccines. We have all these. We're not using the low-dose radiation for treating COVID patients. We're not doing that. But that 2-year gap was very, very important. We generate so much science about low-dose radiation that in the U.S., my own mentee, who was an attending, worked with places from Vanderbilt, wrote a nice review article in the Red Journal and said, hey, what is happening with anti-inflammatory effects for osteoarthritis? Wrote a nice review article, actually. And that review article was downloaded a lot in 2022, 2023. And a lot of people in the U.S. started scratching their heads. They said, hey, wouldn't it be cool to help osteoarthritis patients also that don't have a lot of therapies? And a lot of institutions started scratching their heads. Like, no-brainer. I talked about it in my COVID stuff, that if COVID works, we will see a day in the future that we're going to use low doses for other places where inflammation is a big deal. And it's actually referenced in my earlier papers. And osteoarthritis was something that people started realizing that places like Germany and Europe were actually ahead of us. They were already using low dose for osteoarthritis. Now in the US, we started adopting it. So I started talking to folks at Emory and my leaders and say, let's start offering this. So here's one of the patients. I'll give you an example of how important it is. So this is a patient that comes to me in July of 2025. This is when we got the green light. We're ready to start moving forward. 50-plus-year-old lady who comes in with rheumatoid arthritis, who's on multiple lines of drugs, but her biggest problem was the right hand. And it's bothering her. She's not able to use her right hand. She's had anti-inflammatories, PTOT, steroid injections, and she wears a splint and a brace. And she's already had hydrochloroquine and rituximab for RA, but still not responding and still unable to use her hand. When I clinically examine her, her hands are red. She has MCP joints that are swollen, carpometacarpal joints that are swollen, and a limited grip and a fist formation. And her hand x-rays shows, moderate osteoarthritis of the right index and long finger, and mild to moderate osteoarthritis of PIP. So this is all red and inflamed, and you can see the skin is very tight in those areas, and actually down to her wrist as well. So I'm like, okay, so we're going to offer her low-dose radiation. That's actually one of the first patients we treated. And this is her VAS score. So her VAS score is 8 to 9 out of 10. What that means is she's crying out, almost daily crying, unable to sleep, unable to use her right hand. And that's pretty functional. Imagine not being able to use your right hand. That's a big deal. So I was like, okay, she's not able to drive. She has someone who has to drive her to see me. She wakes up at night crying, and she can't open bottles. And I didn't know that she couldn't open a bottle until I started rating her. I started rating her a sixth fraction. She comes in and she walks in with a bottle, opening it back and forth. And I'm like, what is going on here? Like, she's acting weird. She's like, Dr. Khan, do you realize I couldn't open my water bottles before, and now I can open it? I'm like, wow, that's great. Her VAS score goes from 8 to 9. So VAS is Visual Analog Scale Score. I learned this because I'm not a rheumatologist, but I taught myself, right, because I care about the patients. So it went down to 0 out of 10. So that was exciting. So this is her treatment. We did her for her hand, and she's like, well, 8 to 9 out of 10 is 0. And she's very happy. All the quality of life's improvement. And she actually said, Dr. Khan, you're a miracle worker. So I was happy to hear that from her. This is not the only story. After that, I treated 20, 30 more patients already with multiple joints, continuously hearing this positive things. So I feel like I'm doing the right thing. Germans were smarter. The Swedish were a lot smarter. The Americans are now just starting to catch on. At least I am starting to catch on. Now, preclinical data. Yeah, there's plenty of preclinical data. I'm not going to go into a lot of details. There's plenty out there. Europeans, others have already put that out there. So low-dose radiation actually reduces joint diameter. It can reduce inflammation in the synovial fluids. And you can see how old this is from 1998. So if you dig up the literature, you'll find a lot of old historical data that supports low-dose radiation for osteoarthritis. This is just another sort of biology slide where if you look at half a gray, it reduces patients' pain. This is the biology of macrophages are sort of altered, where you get M1 to M2 macrophage repolarization. There's reduced chemotaxis, IL-1B is reduced, TGF-beta is increased, leukocyte adhesion is reduced. The bottom line is you have osteoblast, osteoclast alteration, where you're favoring bone formation and less bone destruction, and Germans actually support that. There's actually a Russian trial that supports that. There's MRI studies that support this. That I think in the long term, you might actually have some cartilage preservation, which is better than steroids, and maybe cartilage regeneration and bone regeneration. But I think we need more science and data on that. So my lab is actually looking at some cytokine analysis in these patients, the IRB-approved protocols, to really help us sort of validate that. I think that data is still out there, but I think it needs more science on those portions of it. But regardless, patient pains are better, joint functions are better, their quality of life is better. That's no doubt about it. Once again, this is just to highlight that, places in UK, Swiss, German have already been using this for quite a while. At least in the US that I've spoken with, in Georgia and other places, are now just starting to adopt in the last 1 or 2 years. The pain relief is 63 to 90% of these patients are going to benefit. There's many very minimal side effects and negligible late side effects. So patients that are 40 or older, per the German guidelines, they reported the risk is 0.008 to 0.001% of a theoretical secondary cancer risk. Extremely, extremely low. So for me to be able to, for my patient to be able to use their hand and to be able to drive is more important than that 0.008 or 0.15% theoretical risk. So multiple joints have been looked at. Hands, 68% response rates of 994 patient series. Foot and ankle, 75% response rates. In the knee, 79% response rates. Hip, 64% response rates. Overall, about a 75% likelihood of success in about 7,000 patients. These are the randomized trials, because that's the highest level evidence. Iran just came out with this new randomized trial in May of this year. They had 60 patients. Just imagine 60 patients. How big of a signal does it have to be to have a positive trial? So 60 patients, 30 patients get low-dose radiation, and 30 patients get observation, sham, and they're just observed. And they found that they use grade 1 to 3 KLS scoring, and they use a VAS score and lysome scale, and they show significant pain reduction at 6 months. So this is published in the Red Journal. You can look it up. But the Russians also have a trial, 300 patients with a slightly higher dose, and they also show long-term pain reduction, lower rates of arthroscopy and knee replacement. The only caveat to this, there is a negative trial from the Netherlands, small trial, but the main thing, they use 6 gray. One can argue that's higher than what's actually needed for anti-inflammatory effects. If you look at COVID work, when you get about 2 gray and loads of mouse work that we talked about, beyond about 2 gray, 3 gray, you're going to trigger inflammation. But they did 6 gray. But the biggest problem that I see in the trial, they didn't have an upper limit of what osteoarthritis degree did you have. If you look at the Iranian trials and the Russian trials, they limit to grade 1 to 3. Then you're not bone to bone. If you have no upper limit, you have erosive osteoarthritis, you got bone to bone, your pain is not going to get better and it's not going to last long. So I think that may be part of the issue too. So they didn't report any benefit. There's other trials out there that looked at looking at, like, for example, LDRT, low-dose radiation plus glucosamine versus glucosamine alone, showed LDRT actually benefited patients. There's also steroids. We know you don't want to use steroids. Steroids destroy the cartilage. So I think low-dose radiation is a better option than steroids. Okay, I'm going to talk about 2 other new things that I think is emerging. Because of short of time, I don't want to keep you guys here too long. Arthritis we already talked about. I think there's plenty of evidence. We in the U.S. are already starting to use it. We feel comfortable with the evidence. We feel comfortable with the preclinical. So we're starting to use arthritis treatments already. Alzheimer's is emerging. I think there's more data and science that's needed. But there is a phase 2 multi-center trial that was done with 15 patients. 5 of them got 0 gray. 5 of them got 24 centigrade. And 5 of them got 3 gray. And they did pre-baseline 18F fluidometal PET to look at Alzheimer's and plaques and other things that's happening. They used brain MRIs pre and post treatment, and they did neurocognitive testing using this ADS-K-COG scores to look at neurological improvements in this patient at 6 months and at like 12 months. And what they found that there is early data showing Alzheimer's is benefiting. And there's actually mouse models out there with low-dose radiation that also shows that Alzheimer's may actually be impacted, or the Lewis body and some of the other plaques are actually could be benefited with low-dose radiation. And there's another paper I don't have reference here with 5 patients that were hospice appropriate, and they got low-dose radiation. 3 of them actually got out of hospice. Their neurocognitive function would actually improve. So there's early data, but it's not enough for us to start doing it every day. But 5 years from now, we'll see where the science is. congestive heart failure. So my colleague Cliff Robinson, who was involved in doing the cardiac ablation for SBRT, for the tachycardia from WashU, he and I were co-residents together. He did a lot of the early work, the New England Journal of Medicine paper. But what they're doing at WashU is saying low doses of radiation in mice. So what you're seeing is a congestive heart failure in a mouse. So the heart's very large, beating very slowly. And on their website, you'll see that low dose of radiation, the heart is less inflamed, contracted, and actually muscular, working a lot better. So they published this in the preclinical mouse work as well too. So, but I think more human data is still needed. I think they added some human data with SBRTs, what they do with ventricular tachycardia. They looked at low dose spillover to patients that had congestive heart failure as well, and they showed there was some human data on that as well too that suggests there is some ongoing. But I think those are still preliminary. More clinical trials are needed for that. All right, how much time do we have, Majid?
Well, we have a lunch at 2.
Okay, so.
And Juma is sort of.
All right, so I'm just going to glance over this slide really quickly. The bottom line is this is what Dr. Quinn question I asked her. If you look at the data from MD Anderson, which is the Welsh's group, and what they're showing is they do dual checkpoints plus LDRT in the lung cancer mouse model. And what they show that when you add low dose radiation with ablative radiation and dual checkpoint, the low dose radiation actually opens up those metastatic sites that are inflamed, because those inflammation is what causes and prevents CD8 T cells from moving into that area. Tregs, NK cells don't function as well. So low doses can actually open that environment up. So what they conclude is that low dose radiation can, number one, lead to M1 macrophage polarization. So from M2 to M1 phenotype. M1 are more pro-tumor phenotype that'll help lead to destruction of the tumor cells at a metastatic site. Also, you will see increased NK cell infiltration into the metastatic site, and you'll reduce TGF beta levels, which is what Mazur was talking about with LDRT in area. So to me, a lot of people are thinking that maybe the best thing in the future might be low-dose radiation to metastatic sites, and of course your sort of ablative with dual checkpoints or whatever to the original sites. Maybe that's where the future is. So that's kind of the rascopal effect that MD Anderson is talking about. So this one's from Paris, Gustave Roussy. So the guy, the Eric Dosch that I talked about with low dose radiation with COVID paper that he published, his lab published. His lab also published low dose radiation work with 2 grade times 2 and showed that even 2 grade times 2 actually had pretty good survival in some of these colorectal mouse models, and suggesting that 2 grade times 2 with low dose radiation actually has a abscopal effect, what he calls a low scopal effect, so like a low dose scopal effect. And it works something similar where low dose radiation can actually activate cytotoxic T cells, so CD8 T cells that are driving the immune checkpoint, and NK cells are being activated as well. I can go into a lot of this, but I'm not going to do that. But there is a case report out there. Once again, case report doesn't move the dial forward. But in a melanoma, where this case report shows that this patient had failed multiple lines of therapy, including dual checkpoints, including adjuvant nivolumab, and including SBRT 40 gray in like 5 fractions, and still progressed all of that. And then had a new lesion in the mesenteric site. Not quite low dose, but they gave him 10 gray times in 2 gray per fraction, 5 fractions, and actually went into complete response. Just a case report. But I think, to me, I agree with Quinn Lee that I think we still need more science and data when it comes to dual checkpoint plus RT to show that it works. And I think part of that has to do with the type of the model and the design of the trial. I do have a positive trial Quinn didn't mention, but in multiple myeloma, I published a trial last year in Lancet Hematology in multiple myeloma with 25 patients, prospective, that shows a 20% abscopal response rate. It's a positive trial. We're trying to move that to NRG to do a phase 3 trial of that. But again, phase 3 is what we need to really say it works or not. But in summary, LDRT provides a non-invasive, cost-effective treatment option. There is strong preclinical and clinical evidence to support low-dose radiotherapy use for osteoarthritis. COVID, hopefully we don't have to deal with it anymore. But I think it still needs ongoing testing for new indications. We talked about Alzheimer's, we talked about congestive heart failure. We need more trials and more data. And also oncological, like low dose and ablative doses combined with dual checkpoint, I think that's also needed as well. Once again, I think LDRT, what we learned about in the benign indications, will clearly have an impact on the cancer world as well. So just pay attention to that. 5 years from now, I'll ask the same question, and we'll see whether the dial move forward or not. With that, I will conclude. Thank you very much. I know we're running short of time, but I'll take questions afterwards, if that's okay. Good, Majid. Do we have any questions right now, or do we have time, or?
I don't know, at this point, we missed
Probably
him
not,
up.
yeah.
I don't know if anybody has one quick question or two.
Oh, we already missed you up.
Okay, then I think.
Yeah, so good.
Go ahead.
Just a quick one. Thank you for a wonderful work, and really we're proud of doing something out of box in a very challenging environment at that time. Whenever these kind of patients with for benign diseases, they come across these kind of modalities, they're always worried about second malignancy.
Yes.
Any comment on that? How did you address that at the time when you were treating these osteoarthritis patients?
Yeah, so I think that's a great question. So when I started this, I looked at all the science and the data first. I had to get myself convinced. So with COVID, it was very easy because there was no other therapies. The mortality rate was 20% in 28 days when these patients came out. That lady that I talked about with such a high Charlson comorbid index, the internal medicine referred me like, she's going to die anyway, so there's already nothing to lose, so let's do it. And then, so that's how, that was less of an issue. Osteoarthritis, you're actually correct, that was a bit of an issue. It was a dilemma. Then we have to look at, well, what's the trade-off between risk versus benefits? If someone who can't use a hand, someone who's having difficulty walking, I've got one patient who fell 5 times in the last 6 months because her knees are so swollen, right? So in those cases, the risk was very, very small. So looking at the German guidelines, the DEGRO guidelines, and looking at their risk was 0.0018% lifetime risk. And even that, what is that risk? It's a basal cell. And that basal cell is 98% curative. So I was like, to me, it was a non-issue. Then the second thing is, what I want to lead you guys, is this moral and ethical dilemma that you will all face. Because now you have limited resources. You have to decide between treating cancer patients and treating someone who may have congestive heart failure, Alzheimer's, or osteoarthritis. You're going to have to limit your resources. That's a moral ethical dilemma that we're going to have to face, all of us. And I'm already having to face this because my beam time is limited. And guess what? This is what you have to ask yourself. So when you treat a patient with GBM, you're not proving survival. You're just proving local control. But you're destroying their quality of life. Extensive stage small cell lung cancer, local control. You're not impacting survival. Chemotherapy is, but not radiation. Rectal cancer, T1, T2, local control. Worse toxicity. We had a grand rounds where a patient had really bad toxicity from radiation. Low risk prostate, you could also wonder, you don't need to treat it. DCIS. To me, when I look at osteoarthritis, someone who can't use a hand, tomorrow they can use their hand, or someone who can walk. I don't have a moral ethical dilemma anymore when I think about this anymore, after treating them. But in the beginning, you're right, it was a problem.
No, I agree with you because the issue is the actual risk is extremely small, and when we vary speed between the quality of life and the quantity, definitely that takes the priority. But when it comes to the clinic environment and you're sitting with a patient, I think you need to sell it properly.
Yep.
That's all you need to do.
Yep. I agree. You don't want to overdo it too, because you don't want to pick someone who's got bone on bone, who's got really bad. I've got, someone who's got a surgical pain, someone you really don't think is really morally swollen related or edema related. You really need to ask your orthopedic, ask your rheumatologist, who are the patients that are really being driven by their swelling or their edema, all of those, because that's how you're impacting. So to me, it's the Iranian trial, KLS score, from 0 to 3, or the Russian trial, but not KLS for a really bad joint. So.
Yeah, the only other comment I would make is, in our guidelines, we don't use it in anyone less than 40, so it's 40 or plus or more. And we were just talking about this, the studies that shut this down in the US were in the pediatric population, a much higher dose, around 20 gray. So we're not doing that. So, we're being a little bit smarter about how we're doing it. And you can also do smaller fields. You can do CT, based planning. There's a Atlas based out of Spain, doing this. So we're being smarter about it as well. The chances are very low. Okay. So we're going to announce that lunch is at 2 o'clock. That's the reminder. Anyone who needs to say Salah, please do that first.
Good, thanks. All right, thank you very much. Thank you.
got some hope now. I'm not going to do it as a neighbors for clinic
That's what I thought I saw. Yeah. That was here.
But the dilemma is going to be
I'm so embarrassed. I was so embarrassed. I'm like, this should be a slam dunk, no brainer. So easy. Why am I not even doing this?
Introduced SFRT 2 years ago at the conference, and even now we have done so many patients. We are doing using lattice. We don't have grades, so we are doing that. And we have now done so many patients. And I think maybe my next conference we will be showing some benign
Submission
20, 25.